Good morning, ladies and gentlemen. I am Mei Ling, your MC for today. Welcome to the Singapore Geriatric Cancer Public Symposium of 2021. This year's theme is Optimizing Cancer Care for Older Adults. This webinar is brought to you by National University of Hospital, Ng Teng Fong General Hospital, and National University Cancer Institute of Singapore, also known as NCIS. Cancer is currently one of the leading causes of mortality in Singapore. It is estimated that 1 in 4 persons may develop cancer during their lifetime. With an aging population, it has led to a demographic shift towards a greater number of older adults being diagnosed with cancer. This highlights the necessity to support our older patients with cancer, particularly those with challenging health conditions. In this educational webinar, we'll be sharing with you on how a specialized geriatric oncology service can provide a holistic and personalized care plan to older patients by integrating multimodal exercises, nutritional planning, and community resources. Through this webinar, we will also be introducing various support systems that are available for caregivers of older patients. At the same time, we do hope that this session can help you to raise awareness on the importance of recognizing the warning signs for early detection, prevention, and diagnosis of cancers. Before we begin, please take note that your microphone has been muted by default. Please type in your questions in the Q&A chat box, and our specialists will try to answer them as much as possible during the live Q&A segment. Do note that the webinar is being streamed live onto NCIS and Ng Teng Fong General Hospital Facebook page. You may visit these pages to review the webinar after the end of the session and share it with your friends and families. We would also like to take this opportunity to thank our sponsors as AstraZeneca, Eisai, and Pfizer. They helped to make this event possible, and also the people from NUH, Ng Teng Fong General Hospital, and NCIS who helped to put this event together. Without further ado, I'd like to invite Dr. Nidia Camellia to give us a welcome address. Dr. Nidia is a consultant with the Division of Geriatric Medicine from Ng Teng Fong General Hospital and the geriatric lead of the Ng Teng Fong General Hospital Geriatric Oncology Program. She graduated from National University of Singapore, School of Medicine, and subsequently obtained her postgraduate qualifications with Masters of Medicine from NUS and a membership of Royal College of Physicians. She completed her specialist training in geriatric medicine with the National University Health System. She's currently a member of the International Society of Geriatric Oncology and a fellow of the Academy of Medicine, Chapters of Geriatricians. She believes in patient-centered and holistic care in the older adults and is passionate about helping her patients navigate their golden years while maximizing their quality of life. Dr. Nidia, please.
Thank you, Mei Ling, for that kind introduction. Good morning to everyone who has joined us today. It is my great pleasure to welcome you to the second Singapore Geriatric Cancer Public Symposium. It is very heartening to see an excellent turnout despite the nice, cool sleep-in weather this Saturday morning. I am Dr. Nidia and I'm a consultant geriatrician with Ng Teng Fong General Hospital. Well, it's no secret that Singapore's population is rapidly aging. Our life expectancy is one of the highest in the world, with our people living up to an average of 83 years. And with cancer being more commonly diagnosed in the older person, there's an impetus to revolutionize cancer care in our older person, the need for holistic, personalized, patient-centered cancer care. We have excellent speakers across several disciplines who are eager to share their expertise in managing cancer in the older person with you this morning. And together, we form part of a multidisciplinary geriatric oncology team in Ng Teng Fong General Hospital. So whether you're a patient, a caregiver to an older loved one diagnosed with cancer, or simply eager to learn about the nuances in navigating cancer care in the older person, I hope this series of talks will address some of your concerns and clarify the misconceptions. And with that, we'll kickstart the learning journey this morning. Back to you, Mei Ling, to kick us off.
Please welcome our first two speakers, Dr. Ng Ting Yi and Dr. Angela Pang. They are both the program directors of Ng Teng Fong General Hospital Geriatric Oncology Longitudinal End-to-End Program, also known as Golden Program. Dr. Ng is a consultant surgeon from the Division of Colorectal Surgery at Ng Teng Fong General Hospital. He obtained his basic medical degrees from the National University of Singapore. He subsequently completed his postgraduate training in surgery and obtained his fellowship of Royal College of Surgeons from Edinburgh. He has a keen interest in minimally invasive colorectal surgery. He spent a year in Sun Yat-sen Cancer Center, where he trained in robotic surgery and transanal approaches to rectal cancer surgery. He's also passionate about undergraduate and postgraduate teaching with numerous teaching awards. Our second speaker, Dr. Pang, is a medical oncology consultant from the Department of Hematology Oncology at NCIS and is the program director of both NCIS and Ng Teng Fong General Hospital Golden Program. Her oncology specialty is in sarcoma and gastrointestinal cancers. She has obtained her undergraduate medical degree from the National University of Singapore. Thereafter, she obtained her postgraduate qualifications, Masters in Medicine from NUS, and a membership of the Royal College of Physicians, and completed an advanced specialist training in medical oncology in the National University of Singapore. With a specific interest in the optimization of care in elderly cancer patients, Dr. Pang further pursued a graduate diploma in the geriatric medicine with the Yong Lu Lin School of Medicine. In order to integrate her expertise in both geriatrics and oncology, she also trained in geriatric oncology in the Memorial Sloan Kettering Cancer Center, New York, before returning to set up the geriatric oncology service in NCIS. This will be a joint sharing session to explore the unique challenges faced by older adults with cancer. Dr. Ng, please.
Thank you, Mei-Ling. A warm welcome to everyone. Good morning. I'm Dr. Ng, and I'm a consultant in the Division of Colorectal Surgery, Ng Teng Fong General Hospital. This morning, with my colleague, Dr. Angela, we will endeavor to cover some of the unique challenges that are faced by older adults with colorectal cancer. Albert Einstein once said, if you can't explain it simply, you don't understand it well enough. I certainly hope that the contents of my talk today are clear and easily understood by everyone in the audience. I'll first start off with some of the common questions I often hear in clinic. These include, I saw blood in my stools. Do I really have colon cancer? My relative passed away shortly after diagnosis of colon cancer. There is no cure for this. She's 85 years old. She's way too old for surgery. Well, these are relevant questions. These are common questions commonly asked by patients. And I hope that at the end of our talk, these questions can be easily understood and answered by members of the audience. The scope of our presentation today will include some of the common symptoms of colorectal cancer, the current screening guidelines for cancer, the workup of cancer after diagnosis of colorectal cancer, and for the majority of patients who will eventually require surgery, I'll focus in turn on the special considerations in the elderly in terms of pre-operative optimization, making them better before operation, some of the commonly seen post-operative issues, and Dr. Angela will then, of course, focus on the adjuvant treatment journey for this group of patients after surgery. It is perhaps useful for us to go through all these topics with the help of a typical case scenario. We have with me a commonly seen scenario, Mr. Lee, a 75-year-old Chinese gentleman. With the elderly, it is quite common that they have some accompanying high blood pressure, high cholesterol, and he comes into clinic with blood in his stools for around 1 month's duration. Now, is this worrying? Before we go in depth into some of the symptoms of colon cancer, it is perhaps necessary for us to understand some basic anatomy. This is a small intestine. This is a large intestine, the right, and then the left. And then this is a rectum, which leads up to the anus. Just to orientate everyone, this is the direction how food as well as stools flow from small intestines to the right side, to the left side, and then out through the rectum. The symptoms of colon cancer can therefore be largely divided into those of the right side and the left side. What do I mean? From tumors arising from the right side of the large intestine, they often present with very slow, very vague, and very insidious kind of symptoms. This commonly include loss of weight, loss of appetite, and more commonly, what we call anemia, which is a low blood level. Patients will complain of being very listless, very lethargic. Some patients even have syncopal episodes. They have loss of consciousness. They describe themselves as very breathless, very tired when they exert, when climbing a flight of stairs, when carrying something heavy. They have palpitations, or what we call heart beating very fast. And their friends, their families, their loved ones often describe them as very pale looking. Tumors on the left side, which is closer to the anus, on the other hand, appear to be more local in terms of their symptoms. Patients describe having blood, having mucus in their stools. And they also have some change in bowel habits. So what was once normal might now be abnormal. For example, they used to have a bowel habit. Every morning, they will go to the toilet once. But increasingly, this could be lengthened. They also notice a change in their stool caliber. So from well-formed stools, looking like a banana previously, subsequently, they notice that the caliber of the stools is getting smaller and smaller. And now they look pencil thin. They look very thin. Tumors which are very low, near the anus, near the rectum, can of course present with some discomfort in the anus as well. And in general, if the above symptoms are present in any adult 50 years and above, it is advisable to seek medical attention to exclude the possibility of underlying colorectal cancer. And this was exactly what Mr. Lee did. He was referred to a colorectal surgeon and he underwent a colonoscopy. How then do we look for colorectal cancer? The most commonly used method is that of a stool test, or what we call a FIT test, a fecal immunochemical test. Now, this method involves collection of a small sample of stools and sending it to the lab for further processing to look for very small trace amounts of red blood cells or blood. It usually comes in a pair, and if just one of them is considered positive, the entire test is considered positive. And just to give a quick shout out, there are free FIT kits that can be easily available from Singapore Cancer Society. You can check the website for any Singaporean citizen or PR 50 years and above who has not done this test over the last 12 months. He or she should also have not done a scope, which I'll cover later, over the last 5 to 10 years. And it is generally advised that for patients who have no family history, no personal history of cancer, to start doing a yearly stool test from the age of 50. The next commonly used method involves a special CT scan. Now I use the word special because it's more than a normal CT scan. It involves bowel preparation. So we often give the patients some medications to purge, to get rid of all the stools from the colon. In addition, a tube will be inserted through the anus to blow up the intestine to slowly insufflate gas into the bowel. This clean bowel, this distended bowel, will allow our colleagues, the radiologists, to have a close look, to have the best possible chance to pick up any small polyps or lesion during the CT scan. And in general, if either of these two tests, the special CT scan or the stool test, is positive, it is highly recommended for the patient to proceed to a colonoscopy, which of course brings us to the last and perhaps the best method at the moment of screening for colorectal cancer. It is the most accurate, it is most sensitive, and it's also what we call diagnostic and therapeutic. What do I mean? It is diagnostic because it helps us through a dynamic video camera inserted through the anus into the entire colon. It enables us to look for any lesions, and if it's suitable, and they often are, it is possible for us to do some resection, tattoo, biopsy, and other interventions at the same sitting. And again, it is advisable from the age of 50 for patients who've undergone a colonoscopy or the scope, the camera check, to do it 5 to 10 yearly, depending on what we find. Now, when do we stop? We know that this should not go on indefinitely, particularly in the very elderly. If you look through the guidelines, some of the guidelines, such as the US task force, they advocate cessation of this screening at the age of 85. Now, why do they do that? Because they feel that at the age of 85, there's perhaps a level of diminishing returns. Patients are too old, too frail to undergo eventual surgery or chemotherapy, even if we detect colorectal cancer. However, in many other countries and many other physicians, we would like to individualize. We would like to look at the patient profile in front of us, because we all know that not all 85, not all 75, not all 90 years old patients are the same. Those that are still vigorous, those that are still reasonably fit can walk in your clinic. Most of us see no reason why we should stop, because the truth is many patients who are elderly but otherwise optimized, otherwise reasonably healthy, they do well after cancer treatment. Unfortunately, in this case, a tumor was found on Mr. Lee's colonoscopy. Now, this brings us to the next question. What do we do then after we find colon cancer? On discovery of a tumor, the first logical step will be for a biopsy. We will use a forceps introduced through the same scope to take some tissue sample to send for microscopic confirmation. Following confirmation of cancer, we will also proceed to do a tumor marker, a blood test. Now, this has two functions. The first function is it helps to prognosticate. So patients with a very high blood level of this tumor marker tend to do a little bit worse than those with a lower blood level. And it's also for follow-up. Why? Because we know that a high proportion of patients with colorectal cancer will have an elevated tumor marker. Now, this will often normalize or come down nicely after treatment has been completed, after surgery, after chemotherapy. And in future, during surveillance, this test will help us to guide the physician, guide the surgeon, guide the oncologist, whether there is perhaps a higher risk of recurrence. Of course, we like to complete our staging. We all know that cancer can be very early on, from stage 1 all the way to stage 4, which is often not curable. And for certain cancers, we like to do an MRI, particularly for the rectum. And we also like to do a CT scan to look for spread of the cancer to other organs. And the two most common areas for colon cancer and rectal cancer are the liver and the lung. And we come back to our case scenario again. In Mr. Lee's case, a surgery, thankfully it was resectable and the surgery was scheduled. But before surgery, Mr. Lee required a short period of pre-optimization. Now, what needs to be done before surgery? Let us just take one step back. Let us picture for a moment that a major surgery is a race. In fact, it is a marathon. And I think many among us who have ever ran a marathon will know that most of us just do not have the good fortune, the genetics, the capacity to just wake up and run a marathon. Something needs to be done beforehand. This includes good training. So pre-operative patients need some form of exercise, especially if they are frail and not fit. They need good nutrition to recover, to heal. And the often overlooked component, psychosocial support, is just as important, because we know that ultimately there is a price to pay for surgery in terms of recovery. Surgery will result in stress to the body, both the general anesthesia, the medications, as well as the eventual surgery. We know that after surgery, particularly major surgery, even in the young, there is a period of downtime. There will be some inactivity after, with its accompanying issues. And there is a lot of healing to be done after operation, from the skin all the way down to the intestines, which have been resected and repaired. Now let us compare two individuals again. One, a very young, fit and muscular gentleman, and a very elderly patient. Incidentally, this gentleman is 100 years old and set a Guinness World Record for marathon. But despite his supreme genetics probably and fitness, there is no running away from the fact that the risk of mortality in a very elderly patient can be up to 10% for major surgery. This is in part due to their reduced body reserves. The elderly have lower reserves in terms of lung, heart, brain, kidney function. They often have multiple existing medical conditions. And again, as I mentioned previously, the downtime, they are more likely to have a longer downtime compared to a young, fit and muscular person. And it's thus important for us to optimize, to do everything we can to ensure that they have the best possible chance of success after the surgery. There is now good evidence to suggest that this results in a reduction in post-op complications, small, minor, and major, a reduction in hospital length of stay. And with this too, naturally, there'll be a significant reduction in financial costs incurred. Patients are also less likely to be discharged to a rehab facility. They are more likely to go home rather than a step-down care like a community hospital or nursing home. And over at NUHS, both in NUH and Ng Teng Fong, we have in place a MOUSE program. It's aptly named the MOUSE program, which is an abbreviation for Management Innovation for Longevity in Elderly Surgical Patients. Now, all cancer patients above the age of 65 undergoing elective, that means not emergency, major abdominal surgery are automatically considered for this program. What do? We have a trained nurse to do a quick screen, and this includes a nutrition screen. My colleagues will cover later on regarding nutrition. We'll do a frailty screen because we all know not all elderly patients are the same. Some are perhaps a little bit more frail than others. And of course, we will look into the social as well as often forgot the mental state of the patient, because this is after all a very challenging time in an elderly patient. Thereafter, our patient, Mr. Lee, was listed for surgery. But despite our best efforts preoperatively, the truth is, will he recover the same as a young patient? Well, we know that elderly patients tend to have more existing medical conditions that need to be closely monitored post-operatively, especially when the patient is in a state of stress after surgery. This includes things like diabetes, high blood tension, kidney failure, and lung issues. Our elderly patients also have to be closely monitored for a higher risk of what we call geriatric syndromes or conditions that are a little bit more common in the elderly. This includes altered mental status. They can be very confused, from violent all the way to very sedated post-operatively, especially the elderly males. They have a higher chance of urinary retention, depression, higher incidence of hospital falls. Their downtime is expected to be longer than a younger patient, and this often comes with infection, in particular the urine and the lungs. And they're also different. They react differently to surgery. They react differently to medications. For example, a routinely prescribed painkiller might result in a patient being very confused or even having severe constipation or vomiting. Thankfully, Mr. Lee recovered well from surgery and was discharged on day 4 to 5. And this might not have been possible if we did not optimize his fitness before operation. His final histology revealed stage 3 colon cancer. What do we do now? I'll now pass the floor over to my colleague, Dr. Angela, who will take us through the subsequent adjuvant treatment journey for our patients. Thank you.
Thank you, Jingyu. And thank you, Mei Ling, for the kind introduction. So I will share my slides now and carry on from where we had ended. Okay, so hi, I'm Dr. Angela Pang. I'm a medical oncologist consultant from the National University Cancer Institute. So I run the geriatric oncology program both in NCIS, in NUH, as well as in Ng Teng Fong. So continuing from where Dr. Ng had stopped, so basically we are back in the scenario with Mr. Lee KS. So after the surgery, so what happens, right? So then Dr. Ng refers this patient over to a medical oncologist, and there was discussion about chemotherapy. And as with any patient, Mr. Lee's first question is, must I really get chemotherapy and why? So what exactly happens after surgery, and why do people actually need chemotherapy after surgery? After all, the tumor has been removed, right? So the reason being that this is really, the chemotherapy is really, if you conceptualize it, is to prevent the cancer from recurring and from relapsing. Reason being, with research and understanding of colon cancer, we understand that for certain people with higher risk colon cancer, there may be very tiny cancer cells that are already present, but not picked up by scans in various parts of the body, and these may actually result in cancer recurrence. So the purpose of chemotherapy is really to go in and get rid of these tiny cancer cells that cannot be seen on scan. So this is a bit of a technical slide, but basically the typical type of chemotherapy that is given for colon cancer, usually patients with very early stage colon cancer, for example, stage 1, they probably would not require chemotherapy because the risk of the cancer recurring is fairly low. People with stage 2 colon cancer, some of them with higher risk features may actually require a single agent chemotherapy. But as you can see, the number that is quoted here, the improvement in survival is only about approximately 5%. So it may be controversial, and some older adults may say they would rather not have chemotherapy. Whereas for patients like Mr. Lee, his risk of cancer recurring is higher. So offering him chemotherapy actually improves his survival by 20%. So that's 20% versus 5% in stage 2. So perhaps there is a bit more of a justification for him to get chemotherapy. And the typical chemotherapy that is offered for patients with stage 3 colon cancer is 2 chemotherapy medications together, typically 5-FU and oxaliplatin. Usually, most patients will require 6 months of chemotherapy, but for certain patients with slightly lower risk stage 3 cancers, they may be able to do with just 3 months. So the typical types of chemotherapy that we give for colon cancer, there are oral chemotherapy options, otherwise known as capecitabine. The drug company given name is Deloda. Some patients may require oral tablet plus an injection, and that is known as Delox. For certain elderly patients whose kidney function may be poorer, they may not be able to tolerate the oral tablet. So then they will require something that is a bit more cumbersome, which is an infusional chemotherapy pump. So typically the chemotherapy for colon cancer given in an early stage colon cancer setting is given over 6 months. So what are some of the common side effects? So this is probably the most common question that a patient will ask. Some common side effects of colon cancer would be things like diarrhea. Not everyone gets it bad. Hand-foot syndrome. So as the name suggests, hand-foot syndrome basically is some people will get very dry skin and also very thickened skin, and perhaps some of them, when it's bad, it may even blister and peel off. Peripheral neuropathy, which is basically numbness of the fingertips and toe tips. Some people get low blood count. When you have low red blood cell count, you get anemia. When you get low white blood cell count, you may have a severe infection, otherwise known as a neutropenic sepsis. Hey, but the good news about colon cancer chemotherapy is actually you will not lose your hair. So most of the colon cancer patients receiving chemotherapy are actually out in the community looking actually otherwise quite normal. So then, our talk today is about cancer in the elderly, right? So a common question that I typically get in our older adults with cancer is like, why me? Why am I so sway? But actually, the actual reality is that 60% of all cancer survivors are actually above the age of 65. Probably because we do have an aging population. And as you age, the incidence or the likelihood of developing cancer is higher. And also, we are doing better in treating patients with cancer that's diagnosed early. So actually, there's an increase in the length of cancer survivor in our patients. But what very important then also is, if you do have life ahead after being diagnosed and treated and cured of your cancer, treatment decisions do often impact on your survivorship and your quality of life subsequently. But most importantly, it's kind of quite important to remember that you're really not alone. You may actually turn to your left and you see a friend who's been in the same situation as you, and so on. So really, it's quite manageable, and there are plenty of resources out there to help older adults with cancer. So as the graph here shows, in Asia, more than 55% of all cancers actually occur in people aged 60 and above. And as Dr. Ng alluded to earlier, some of the challenges faced by an older adult with cancer would be that several older adults do have other medical problems. Medical problems, the technical terminology is called comorbidities. They have diabetes, perhaps heart disease, high blood pressure. So about 80% of people above the age of 65 may have at least one. 50% have two. And the fact is that as you get older, there's a higher likelihood of developing a second or even a third cancer as you get older. So by the time you reach about 80 years old, there is actually about approximately 12% of developing a second cancer. And of course, as you age, your body organs and such, it may degenerate. So you actually may have lower physiologic reserve. So as this graph here shows, by the time you hit 30 years old, a lot of your organ function starts to decline. So when you hit about 65, the decline will be quite palpable. You can really feel it quite significantly. When you hit 80, it's even further down, and so on. But it's never, or rather we should say that, being diagnosed with cancer really, it may be very scary, but it's really not the end of the world. And we would say after you have calmed yourself down about after being diagnosed with cancer, there are some very important things to take note of. Really, it's about understanding what your treatment options are, and don't be afraid to ask your doctor. We may be medically trained, but we also need to have a conversation with you to understand what is important to you. And what's also important is about staying safe and as independent as you can during your cancer diagnosis and cancer treatment. Because if we get it right, the outcomes are that we can cure you from your cancer and also not deprive you of your quality of life and your day-to-day activities and so on. What actually in our Asian population we tend to not talk about is emotional health. So the fact is that of course the diagnosis is very scary and you'll be very scared, but you don't dare to talk about it. But that part is actually very important. So if you have very close family members, you can always talk about it. If let's say talking to family members, you're worried that it would worry them, you can talk to your friends and so on. So long as there's someone that you can talk to, or even the healthcare team will be very happy to listen to you if you are willing to open up to us. So these are some of the questions that we would encourage patients to ask. So really, it's good to take charge of your own health and understand, like for example, what stage of cancer do I have? How was it diagnosed? What are my treatment options and their side effects? Can I talk to you about the treatment outcomes that I want? So before making any treatment decision, besides talking to your healthcare team about the above questions, the other question to also ask is really like, would the treatment impact on my physical, emotional health, and also my lifestyle? And some other considerations would be, what is the most important to you as a person? How is your social network support like? And do you think you would foresee facing any financial challenges? So these are really just some questions to kind of think about. But we have a very we have a lot of resources to be able to help you with all these situations. So it really, if you tell us about it, we would be able to offer you assistance. And what is also actually really important to think about would be, what are your cancer treatment goals? Is it very important to you mostly to be cancer free or living longer? Or actually all you want is to have very minimal symptoms from the cancer and side effects of treatment? Or maybe you just want to maintain your physical health, so you don't want to like be too tired or too breathless, and you really want to maintain your independence. And some people say, all I want is to have a good quality of life. I don't want to think so much about all these things. And really, older adults are just as likely as younger adults to be cured from cancer. And what actually matters the most is what matters to you. So cancer treatment methods, as Dr. Ng had mentioned earlier, there will be surgery. So some people may need just one type of treatment or a combination of treatment. So chemotherapy is the other type of treatment, and also there's radiation. So your doctor will recommend a treatment method or combination that is the most suitable for your condition. Different types of cancer may require different treatment. So your friend who also has cancer may not necessarily need to receive the same type of treatment as you. So cancer surgery, like all treatments, surgery does have its own risk. As Dr. Ng mentioned, how to recover faster after surgery really is about what we can do before your surgery to prepare you with optimization, using exercise, and also some dietary advice to boost you up before you go for your surgery. So unlike surgery, chemotherapy is what a lot of people fear. It's typically given over a longer period of time, and your oncologist will discuss with you if you will require chemotherapy for your cancer. So most older adults are very concerned about the side effects of chemotherapy, and common side effects may include low blood counts, stomach and digestion problems such as diarrhea and vomiting. But these are side effects that are very easy to manage, and usually we have very good medication for that, and also some numbness of the hands and feet. Radiation therapy. So radiation therapy is usually given over a short period of time, but it does require you to come daily on Monday to Fridays for a fixed period, for example, over 4 weeks. But each treatment session is actually quite short, maybe about 5-10 minutes, so you'll be able to go home quite quickly after that. So side effects of radiation therapy generally quite well tolerated, but it will really depend on where the cancer is located. So then we'd like to introduce to you the role of a service called the Geriatric Oncology Service that is really specializes in the care of older adults with cancer. So what exactly is geriatric oncology? So as the two words suggest, it is an integration of two different specialties. Geriatricians like Dr. Nadia, their specialty is really about managing medical problems that older patients have and maintaining their functional status and optimizing their independence, even all the way to, they're really very elderly, even in their 90s and so on. Whereas for oncologists like myself and Dr. Ng, we really would look at the cancer variables such as the tumor biology, stage of the cancer, and we develop very specific cancer directed treatment plan. So a geriatric oncology service actually consists of a multidisciplinary team of many people or doctors from different specialties, nurses, social workers, dietitians, physiotherapists, and occupational therapists who will work very closely together to optimize the care of older adults with cancer. So for the geriatric oncology service, we do use a comprehensive geriatric assessment, otherwise known as a CGA. It is a very important tool with 7 domains that are used for the evaluation of the health status of an older adult. So we look at things like your activity level, functional status, what other medical problems you have, whether you have any problems with your memory, how is your nutrition like, how's your emotional health like, what's the social network support that you have, and what medications are you taking. It allows us to have a thorough understanding of your overall health so that the medical team can direct your treatment accordingly. So in geriatric oncology, we don't just look at the cancer, we also look at the patient. So we stage the cancer and gauge the disease prognosis, treat the cancer as aggressively as possible without too much side effects. We also stage your aging. How fit are you for your age? Age is just a number. We really want to know, despite your age, maybe you are actually relatively fit. You may be 80 years old, but you're as fit as someone in their 60s. So that actually is very important for us to gauge how aggressive can we go with your treatment. Then together we will discuss with you your preferences, what are your expectations, and what are your treatment goals, and then we'll communicate across and come to a treatment plan that is the most ideal for you. So back to Mr. Lee. So, he was not very sure whether he should get chemotherapy or not. So, he was referred to see us in a geriatric oncology clinic. We did a comprehensive geriatric assessment for him, and we realized that, well, he's not too bad for his age, but he's lost a bit of weight after the surgery, and he does feel a bit weak in his knees. So we did optimize him by getting our dietitian to give him some dietary advice, how to eat better, and then we got our physiotherapist to work with him. And by the time he was optimized, he went on to receiving chemotherapy, and he really tolerated it very well. So how exactly do we improve the quality of life for older cancer survivors? So some of the survivorship issues in older adults are that they do have a bit more functional limitations compared to their peers. Some late treatment-related complications would include cancer-related fatigue, cognitive function decrement, as well as numbness due to chemotherapy, and patients then would be at a slightly higher risk of falls. And last but not least, bone health issues such as osteoporosis. So then back to Mr. Lee, he's finished his chemotherapy, then his question is, then can I still live well after my cancer diagnosis? So now he is about 3 years, almost 4 years out. He's a colorectal cancer survivor, and he's still very independent without any long-term side effects. So the fact is that there are patients who are able to survive their cancers. So do not be afraid. There are many people who are able to survive their cancer. So there's even a National Cancer Survivors Day to celebrate, the triumph of all the patients out there. And we are all also very happy for patients like this. So really, like, what other strategies do we have to improve the quality of life for cancer survivors who are elderly? So we actually identify who are the ones who are at higher risk of chemotherapy side effects. And then we evaluate what is the long-term impact of the cancer treatment on your underlying health and how do we prevent it. And of course, exercise is actually very important. We cannot stress it any less. It is very important to maintain one's quality of life as well as functional independence. And we also take care of your bone health and other medical problems. So this is a tool that we use to predict for one's chemotherapy-related potential side effects. And with this, it allows us to guide your treating doctors to see whether it really, what is your risk of developing side effects. If it is indeed very high, maybe we would advise them to step back a bit and have a discussion with you before proceeding with the chemotherapy. So older cancer survivors may be at slightly increased risk of falls, especially those who are slightly older. So it increases the percentage of risk of falls increases to 50% in those who are aged above 80. So so about 10% of them would actually develop injuries after the fall. So the way to really prevent it is once again exercise, balance, strength and endurance exercises, environmental factors. So it is very important for older adults to have proper shoes, proper footwear. Flip-flops and slippers are bad because you can imagine if your flip-flop were to catch onto the corner of, and get wedged into some corner, then it's going to flip. So usually we will advise older adults to wear good footwear like sport shoes and such. And also to make sure that within your house, you don't have too much clutter, so you won't trip over your own furniture and items on the floor. So for older adults who live alone or they don't have help, if they have visual problems, we usually have to address it as well. And we have to reduce the number of medications that can make people drowsy and really avoid chemotherapy that can cause numbness. So last but not least, we don't just do the CGA, which is a comprehensive geriatric assessment for the sake of doing it. We also use it as a tool to pick up problems. So in each of the domains over here, if we do pick up a problem, we would send you for the respective interventions that are required. And who carries out the intervention? So as I mentioned, in the geriatric oncology team, we have a huge team of various members from different allied health subspecialties, of which several of them are going to be speaking today to explain to you a bit more about what they do and how they can help you, help older adults with cancers manage their lives better. So as I mentioned earlier, it is really very important to stay active with exercise in older cancer survivors. Exercise does aid in the reduction and in the risk of functional decline. It improves your bone health. That means it reduces your risk of osteoporosis, and it also reduces cancer-related fatigue. And in some people, it actually does. It has been shown to improve cancer survivor, outcomes. So in conclusion, this is my conclusion slide. Majority of cancer survivors are actually 65 years and above, up to 60%. And it is true that older adults with cancers do face challenges associated with physiologic aging, comorbidities, as well as geriatric syndrome. But it's still really important to understand your own health and your medical condition. And don't be afraid to discuss with your doctors your treatment goals and preferences. So here we are, our geriatric oncology service. We are here to really provide guidance in treatment of older adults with cancers, and also to provide multidisciplinary support for whatever interventions that you will require. And we use this thing called a comprehensive geriatric assessment, a CGA, for us to have a thorough understanding of your overall health and direct your treatment accordingly. Last but not least, we have to be proactive to stay active, to maintain your functional abilities, bone health, and survival in older adults with cancers like yourself. So with this, I'll say you can do it. So we really want to advocate for older adults with cancer to come forward to get treatment and not be too afraid. Because if we can, to the best of our abilities, we will help to guide and direct your treatment so that you can do the best as you can. So thank you. We're happy to take any questions via email. So this is Dr. Ng's email and this is mine. And with this, next up, we would be showing a short video clip on the purpose of a geriatric oncology service and how we optimize cancer care for older adults.
Whether you're a patient or a caregiver, the cancer journey is never easy. You're probably feeling worried or lost. Maybe you even feel like there's no point in going for cancer treatment. You're not alone. Most older cancer patients are worried that their age determines their health and their treatment outcomes, and that they have no say in their treatment. But with the right mindset and the right treatment plan, you can still live well, even with a cancer diagnosis. Let's look at these common misconceptions. First of all, age is less important than you think. Let's take Ben as an example. Ben is a 70-year-old diagnosed with cancer. He thinks he's too old and therefore too weak to tolerate cancer treatment, so he decides to refuse cancer treatment altogether. But each person's health is actually determined by many factors, such as their psychological and social circumstances, their fitness level, and other medical conditions. For patients like Ben, an in-depth assessment can help them find suitable treatment options. They don't have to say no to treatment just because of their age. Secondly, being older doesn't always mean that treatment should be reduced. Studies show that aggressive cancer treatments don't only benefit younger patients, older patients can benefit from them just as well. There's no need to deny the full range of treatment options or cutting-edge therapies. If they're appropriate for you, your doctor will let you know. Finally, being a patient doesn't mean that you can't speak up. Some patients think that professionals know more than them, so it's better to just let them talk. But if you share more about yourself, such as your personality, lifestyle factors, goals, and preferences, your doctor can use this information to choose the most suitable and available treatment plan for you. Getting to know more about your diagnosis also helps you manage your condition better. You can ask questions like, what stage of cancer do I have, and how was it diagnosed? What are my treatment options and their side effects? Can I talk to you about the treatment outcomes that I want? Being involved in your treatment will help improve your quality of life more than simply taking a back seat. But cancer treatment can still be complicated, especially for older adults. That's why the National University Cancer Institute Singapore has introduced a geriatric oncology service available at the National University Hospital and the Ng Ting Fong General Hospital. This is a comprehensive service that brings you, your family, and a multidisciplinary team of healthcare professionals together to assess your fitness for cancer treatment and help you decide the best treatment choice to achieve the outcomes you want. If you are likely to benefit from the service, your doctor will refer you to our geriatric oncology team. You will meet a nurse, a pharmacist, and a consultant who will ask you a range of questions about yourself. We may then refer you to a dietitian, medical social worker, or therapists as needed. In this way, we can provide you with care that is tailored to your personal needs and goals. If your family members are with you in your journey, our service offers care navigation and caregiver support for them too. Our team is here for you and your family every step of the way. And remember, your age doesn't change the quality of life you deserve. Ask your doctor about the Geriatric Oncology Service or contact us today.
Thank you, Dr. Pang and Dr. Ng. It is indeed a very insightful sharing, and I think that the animation video itself provided a very concise and comprehensive information on what a geriatric oncology service is. Next up, we have Dr. Nidia. She's a consultant from the Division of Geriatric Medicine at Ng Ting Fong General Hospital. Dr. Nidia will be sharing with us on how to thrive well, even with a cancer diagnosis, with her talk, Thriving with Cancer. Over to you, Dr. Nidia.
Thank you, Mei Ling, and hello again to everyone who has joined us this morning. Let me share my slides. Okay, so My talk today will focus on frailty in aging and how this influences one's cancer journey. And hopefully with this knowledge, we can prepare ourselves better for the road ahead. So cancer is common. It is so common that statistics have shown that 1 in 4 people may develop cancer in their lifetime. And the older we are, the higher the chances of developing cancer, simply because our cells have had more time to undergo damage, and problems with repairing these damages causes cancer. If we look between the years 2014 to 2018, the number of people diagnosed with cancer is 100 times more in the age group above 80 than in those under the age of 30, in both men and women alike. And this translates to 41% of cancer diagnoses being made in men and 32% in women above the age of 70. So we know that a cancer diagnosis at any age is definitely frightening. However, with early diagnosis and improved treatment options, more people are surviving cancer with better outcomes. But the question we often ask is, does this hold true with the older person as well? Will the older person be able to receive the same treatment options as a younger person? And are they still safe? Will an older person be able to tolerate side effects? Will they have good quality of life? And will they suffer? So these are some thoughts and possible reservations that you may have. And today we are going to demystify the effects of aging on the cancer journey. So cancer and its treatment can affect the older person in more ways than it does the young. However, what we need to realize is that it is not the age that actually matters. And why this is so is because age is not a good determinant of health. A common misconception is that a loss of resilience and ill health is an inevitable consequence of aging. However, the older person is very heterogeneous, very different in terms of health and functional ability. They lie along an entire spectrum of fit to frail. If you look at the pictures from on the left, these are Japanese pearl divers. They are robust Japanese pearl divers, or called amas. They would dive for pearls with no oxygen tanks way into their 70s and 80s. And then we have the frail older person who requires a caregiver to assist them in their activities of daily living, such as showering and feeding, and everything else in between. So varying health status and all within the same age group. So the reason why each older person can be so different in terms of their health status is because of the many different aspects of our lives contributing to our overall well-being. These include medical factors, social issues, physical, as well as psychological factors. So our quality of lives really depend on the interactions and balance between these different aspects. So if a certain factor is putting your quality of life at risk, this creates vulnerability. However, if they are reducing this risk, they count towards our resilience. So if we consider a young adult, he will likely have factors which makes him resilient. So even if he develops an illness which makes him vulnerable, he has enough resilient factors to counter this and therefore maintain his overall health and well-being. So however, over time, the influence of the different factors change. In the elderly, when more components are stacked on the vulnerability scale, the balance tilts, and this is known as frailty. So the older you are, the higher your chances of frailty because of this shift in balance. So how then does frailty affect your cancer journey? So let's consider a young adult who has been diagnosed with cancer. So the management of his condition is likely to be disease-focused or disease-centered. He undergoes treatment specifically targeted to his cancer. He would have little other medical conditions, functional or social factors that will significantly affect his journey. So now, because of vulnerability of the older, frail person, the cancer journey is not going to be as straightforward. So let me illustrate this with our patient, Mr. Tan. So Mr. Tan is a fictional character, but he represents the older person's treatment journey that we have become all too familiar with. So Mr. Tan is a widower who lives alone in his 3-bedroom HDB flat. His 2 children are married and they live apart. He is independent and uses a walking stick when he goes out in the community. He sees his GP regularly for some medical conditions. He has diabetes, high blood pressure, high cholesterol, and a large prostate. This has caused him nerve problems, causing some numbness in his feet. He is on medications as well as insulin. And the enlarged prostate was causing him to wake up 3 times a night to urinate. So Mr. Tan has been experiencing some bleeding during his bowel movements and losing weight over the past 3 months. He had a colonoscopy, which showed a growth in his large intestine. So a colonoscopy is a camera inserted through the anus to look into the large intestine. And unfortunately, the biopsy of the tumor confirmed a cancerous growth. So a surgeon recommended that he undergo surgery to remove the tumor, followed by chemotherapy to reduce the risk of recurrence. So what we would expect Mr. Tan's journey to be is modeled after our understanding of what the younger, more robust individual might go through. However, more often than not, we see a very long and arduous journey taken by the older person like Mr. Tan, which often results in very different outcomes. So let's journey with Mr. Tan. So Mr. Tan underwent a surgery to remove the tumor, and he had a stoma created. So a stoma is an opening in the abdominal wall that a surgeon makes in order for waste to leave your body. And remember that he lives alone. So he was discharged home after the surgery back to his own home. Unfortunately, he had some loose stools from the stoma site, and his doctor gave him some medications. As discussed before with his doctors, he was started on 2 chemotherapy medications to lower his risk of recurrence. After starting chemotherapy, he developed some nausea, a bit of poor appetite, and the chemotherapy medication was worsening the numbness over his feet, which he already had from the long-standing diabetes. Because he's a good patient, he continued taking his diabetes medication, he continued taking his high blood pressure medication as prescribed by his GP. Unfortunately for Mr. Tan, one day he woke up in the middle of the night, as he always do, to pass urine in the toilet. He got up, and because he was feeling a little bit weak, he wasn't eating very well, his blood pressure medications were not adjusted, he felt dizzy, he lost balance, and he fell. And because he was living alone, he was not found until the next morning when his son brought him breakfast. So Mr. Tan went to the hospital, and unfortunately, he sustained a hip fracture. He underwent hip fixation surgery, but because of the pain, he was not able to walk for 3 days after the surgery. And because of this immobility, because of the pain, because of the medications that he was on, and on top of it, he already had a large prostate to begin with, he developed urinary retention, or he wasn't able to pass urine on his own, and a tube was inserted to help relieve his bladder. And now remember, Mr. Tan is on a walking frame with crutches. He has a tube coming out of his genitals. He has a stoma bag, which is emptying his waste. Because of this decline in his function, he had to undergo physical rehab for 2 weeks in a community hospital. And since no one was there to look after him as he goes home, and he now needed assistance in his activities of daily living, he was sent to a nursing home with a walking frame, a catheter, and a stoma bag. So as we can see in this scenario, Mr. Tan's frailty made him very vulnerable when the treatment is focused on curing the disease alone and not looking at the patient as a whole. And frailty leads to very poor health outcomes. So when the frail older person with cancer needs is actually a holistic and multidimensional management. And there are 3 key pillars in managing an older person with cancer. 1, we need to increase our resilience so that we can better counter the vulnerabilities that come with cancer and cancer treatment. 2, we need to be proactive, because once complications arise, it can be hard to undo them. Often it becomes a slippery slope. So we need to preempt problems so that we can intervene early to avoid problems down the line. And number 3 is to adjust your treatment based on your health, not your age, your health and frailty status. So it is not a one-size-fits-all treatment in the older person, because we know they can have different levels of health status. So your management should be personalized, it should be individualized. So number 1, increasing your deposit in your resilience bank. So first up is your exercise bank. So this article in the Straits Times published in December 2015 mentioned that a focus on exercise has made our elderly stronger and better able to tolerate cancer treatment effects. And studies have shown that exercise can counter many common side effects of cancer as well as its treatment. For example, fatigue, psychological distress, as well as increased quality of life. And exercise has also been shown to decrease the risk of cancer recurrence, cancer death, and overall death by 20 to almost 50%. That's almost half. And therefore, all patients with cancer should avoid inactivity. They should progress to regular exercise, and they should tailor their exercise routine according to their physical ability as they journey through cancer and its treatment. And as what Dr. Ng has said earlier, exercise prior to surgery has also been shown to result in fewer deaths and complications. And many hospitals such as Ng Teng Fong and NUH are actively prehabilitating the older person, which is exercise and nutrition prior to surgery rather than after, because of all the significant benefits. And this is especially relevant to our older person who may be offered surgery as a treatment option for their cancer. And secondly, in our resilience bank is our nutrition bank. So in general, you must take enough nutrients for your body to function at its best before, during, and after treatment. However, we know that cancer and cancer treatment can disturb this balance because one, cancer itself increases your body's demands for nutrients, but at the same time, cancer or cancer treatment can affect your appetite and you end up taking in less than what you need. And to make matters worse, and if that's not already confusing enough, older person may also have existing health conditions such as diabetes and high blood pressure with other nutritional conditions. And so making sense of eat more of this and less of that becomes even more challenging. So this is where our nutritionists help make sense of our individualized nutritional requirements and advise us accordingly. Our second key pillar in cancer management in the older person is to be proactive and not reactive. Cancer and cancer treatment do not occur in isolation, especially in the older person, because they have other medical conditions which adds another level of complexity to cancer care. So they can potentially interact with cancer and make the side effects of cancer treatment even worse. So this converse is also true when cancer and its treatment can also affect the underlying chronic medical condition. So what needs to be done is an early review of your existing medical condition and adjustment to your chronic medications with your doctors. And this is definitely crucial. And other proactive interventions include linking up with community services early, such as meal services, rehabilitation centers, identifying and training a caregiver in anticipation of the older person requiring assistance with their daily activities of living, and having conversations truly about what matters to you and what do you want out of your cancer treatment. So anticipation and early intervention of these medical, functional, and social issues will definitely set you up for a smoother journey. And the third key pillar is treatment adjustment, not based on age, but based on health and frailty status. So we know that because an older person lies on a wide spectrum of fitness and health, treatment must be individualized. So this includes the choice of treatment regime based on the intention of the treatment, the combination of chemotherapy drugs, as well as the dose of chemotherapy drugs. And these principles also apply to adjustments to treatment of your underlying chronic medical conditions. So coming back to Mr. Tan, having a better understanding of these three pillars in cancer management, let's apply these approaches to Mr. Tan. So just to recap, the three pillars are: one, increasing your resilience; two, proactively anticipating the complications and problems; and three, individualizing treatment. So let's look at Mr. Tan. So initially he underwent a surgery to remove the tumor. He did not have any prehabilitation. So prehabilitation to increase his muscle strength and functional reserves will definitely help with the post-op recovery. And knowing that he lives alone, a hospital-to-home transitional program where case managers from the hospital can follow up with Mr. Tan when he gets discharged to anticipate and follow up on potential problems he may face when he's alone at home. Then he had loose stools from stoma side and given medications, and he was started on 2 chemotherapy agents, which were created potential problems down the line. So what could have been done was chemotherapy medications and doses could have been adjusted in view of his underlying medical issues, and he already had pre-existing nerve problems. And thirdly, being a good patient that he is, he continued taking medications as prescribed from his GP. But we know now that he probably needs some adjustment of his chronic medications. He wasn't eating very well, and his diabetes medications need to be adjusted. He wasn't drinking very well, so his blood pressure was too tightly controlled, and his blood pressure medications could have been reduced at this stage. And unfortunately, he woke up in the middle of the night to use the toilet as he usually do. But we know that because of his increased risk of falls, knowing that he wakes up multiple times at night to urinate, he could have benefited from some home modification and equipment. So looking at home safety and providing a urinal or bedside commode could mean that he does not have to wake up and ambulate to the toilet at night. So this would have decreased his falls risk and not have him landed up in the hospital with a hip fracture. Unfortunately for him, even at this stage, when he underwent surgery for his hip fracture, he was unable to walk for 3 days because of the pain. So early rehab and pain control could be the difference and could mean that he could rehabilitate earlier and not lose muscle mass and function lying in bed in the hospital. So early rehab and promotion of continence could also have prevented urinary retention and a catheter insertion. So these multidimensional interventions could have prevented a slippery slope to dependency and ultimately could have helped avoid Mr. Tan's landing up in the nursing home. So I hope my talk today has dispelled some misconceptions about the effect on advanced age on cancer. And here are some parting thoughts and messages that I hope you would find useful as guiding principles in navigating the cancer journey as an older person or a caregiver of one. So one, age is, we've repeated this ad nauseum, but age is not a good determinant of health. And an older person should not be excluded from treatment purely based on how old they are. 2, cancer management in an older person should be holistic and multidimensional to obtain the best possible outcome. And this should be done by 1, increasing your resilience through exercise and nutrition. 2, being proactive, so anticipating problems and intervening early. And 3, individualizing treatment based on your health status after a discussion with your doctors, because we need to remember that an older person has different frailty levels and treatment should not be one size fits all. And with that, I thank you for your attention. I hope this talk has been useful and I wish you a fruitful remainder of the symposium. Thank you.
Thank you, Dr. Media, for the very informative and enlightening talk. Moving on to the next session, please welcome our next speaker for today. Ms. Chan Si-ying is a physiotherapist from the Department of Physiotherapy at Ng Teng Fong General Hospital. Si-ying provides education to older adults on how to exercise safely to improve their functional outcomes. She'll be sharing with you on the benefits of pre and post treatment exercise for older adults. Si-ying, please.
Hi, everyone. I'm Si-ying. Today, I'm glad to be here this morning and sharing with you about the benefit of exercise before and after the cancer treatment, especially in older adults. So the cancer treatment just mentioned by the doctor, it include surgery and adjuvant therapy such as chemotherapy, radiotherapy, hormone therapy, and targeted therapy. Many patients may undergo adjuvant therapy after surgery to destroy the remaining cancer cells and reduce the chance of cancer coming back. For the treatments, remove and kill cancer cells. In the process, they may also damage healthy cells and cause some side effects. So there are some common post-operative complications, which was mentioned by doctors earlier on, which includes infections, pulmonary complications like pulmonary lung collapse or pulmonary infections. Deep vein thrombosis means a blood clot formations in a deep vein, which usually develop in lower limbs, and when part of the clot breaks off and it travels to the lung, can cause a blockage called pulmonary embolism. So if the clot is large, it can stop blood from reaching the lung, and in some cases, it could be a life-threatening event. So other side effects like fatigue, pain, weight loss, muscle weakness, all this can result in longer hospitalization, and the patient will have longer time rest in bed. Some other side effects of adjuvant therapy, like diarrhea, nauseous, vomiting, loss of appetite. These are some symptoms that can happen acute during the treatment, while some of other side effects may appear later and be longer term, like fatigue, peripheral neuropathy, which means the tingling sensation, numbness, or pain in the arms or the legs. Lymphedema, swelling of part of your body like glands, osteopenia, osteoporosis, weight loss or weight gain in some cancer treatment, muscle weakness, and also it might increase the cardiovascular complications like increase the heart disease risk. So both symptoms of cancer and the side effect of cancer treatments can cause significant physiological stress to our body. With advancing age, older adults with cancer often face reductions in functional capacity. So malnutrition and sedentary behavior can further exacerbate the decline in function during and after the treatment. So in this chart, it shows the trajectory of aging, frailty, and acute illness or hospitalizations associated disability. While the green line represents aging in a healthy way, means a person can maintain the functional capacity and being able to do things that we value for as long as possible. The blue line shows the functions of people who has suboptimal health conditions, and the red dot line represents the acute illness or hospitalization. While the person of a younger age can function normally, older people at pre-field or field stage, they are more vulnerable to adverse effects of hospitalization. So if they encounter acute illness or hospitalization, they could have a step decline in their physical functions and require assistance in activities of daily living. So if the condition is not improved, they will likely become more dependent and end up bedridden. We know that with rehabilitation, like exercise, nutrition, and social support, which represent in the green arrow here, it helps to lessen the impacts of hospitalizations or acute illness on the functions and eventually lengthen the period of life that is free of disability. So other than rehabilitation after hospitalization or surgery, what can we do before the upcoming cancer treatment that could weaken our functions? So as shown in this picture, with pre-rehabilitations, we can build the fitness level of more frail patients to a higher level. So after surgery, if their function decline, they will have sufficient reserve to withstand the loss of functions as compared to the patients without pre-rehabilitations. So patients with pre-rehabilitation will also likely to gain better improvement in the rehabilitation if it's required after surgery. So in cancer treatment, the pre-treatment conditioning can help to lower the risk of developing post-operative complications, and the patient can have shorter hospital stay. It can also improve our physiological reserve and functional capacity, and potentially reduce the impact of side effects of adjuvant therapy. As if you're fitter, you are more likely to tolerate the side effect of treatment better. So according to the evidence-based recommendations from the American College of Sport Medicine, exercise during and after cancer treatments is safe, and cancer patients and survivors are suggested to do at least 150 minutes of moderate intensity or 75 minutes of vigorous intensity aerobic exercise every week. For muscle strengthening activities, to do on 2 or more days a week that work on all major muscle groups. For older adults, they should do multiple component physical activities to improve physical functions and decrease the risk of fall. So what is a multi-component exercise program? This is the one that includes different types of exercise. So aerobic exercise, it moves those large muscle groups and cause your heart to beat faster. In long term, it can help you to improve your heart and lung functions. So some exercise like brisk walking, swimming, cycling are aerobic exercise. And as we age, we lost muscle mass. So strength training can build strength and muscles to help us feel more confident and capable of doing daily tasks like carrying grocery, lifting heavier objects around the house. Strengthening exercise with resistance, it helps to improve bone health as well. Aging also leads to a loss of flexibility in the muscles and tendons. So, and also cancer treatment like surgery and radiation therapy can cause part of your body become more stiff. So stretching the muscles routinely make them more flexible, which increase your range of motion, reduce pain, and the risk for injury. So for older adults, balance exercise can train your reactions and balance, so can help us to walk and move more steadily and reduce the fall risk. The example of the exercise like standing on one leg and Tai Chi is quite popular as well. Here we can use this physical activity pyramids as a guide to help us to plan out our physical activity in a week. So it will become a routine part of our daily life. The optimal goal is to gradually increase the amount of physical activity, and decrease the inactive time. So firstly, we try to walk more often and be physically during the days, like doing housework, gardening. So for the moderate intensity and vigorous intensity of aerobic exercise, we can do 3 to 5 days a week. So moderate intensity means that you need to breathe a little bit harder, but can still talk, but not sing. Vigorous intensity exercise, it will make you feel shorter of breath and need to pause to speak. So don't forget to do 5 to 10 minutes of a warm up and cool down before and after the exercise. The 150 minutes each week sounds like a lot of time, but actually it's not. That could be 30 minutes a day, 5 days a week. And the good news is you can spread the activity out during the week. So you do need to do it all at once. You can even break it up into smaller chunks of time during the day, like 10 to 15 minutes for a few times a day. So for the muscle strengthening exercise, to do 2 to 3 days a week for the major muscle groups in your arms, limbs, and the trunk. After the strength exercise, it's good to do some stretching exercise also on the major muscle groups. So it's a good cooling down exercise as well. So for older people, don't forget a balanced exercise. You can do at least 2 to 3 days a week, help you to reduce fall risk. And finally, limits the inactivity, like don't sit more than 1 hour. So you can try pedal cycling or marching on the spot while you are watching TV, or like right now when you are listening to us. Here, I would like to share a video with all of you. Okay, so this video shows us how exercise can help us doing our daily tasks more effectively and safely. And from the other point perspective, when you're being physically active, you are actually already doing some form of training. So this is the infography outlines that the effects of exercise on health-related outcome in those with cancer. So for all adults, exercise is important for cancer prevention and specifically lower risk of 7 common types of cancer. And exercise after a diagnosis of breast, colon, and prostate cancer is associated with longer survival. Exercise during and after the cancer treatment can improve cancer-related fatigue, health-related quality of life, physical functions, anxiety, depressions, and sleep. The resistant exercise does not exacerbate lymphedema, and it actually has positive impact on the bone health. Here are some tips for patients doing exercise during their cancer treatment. So try to stay active as possible and continue your exercise if you are feeling well. And always start slow and progress your exercise intensity gradually as you can tolerate. Exercise intensity and duration should be adapted based on your presentation on a daily basis. If you need it, can reduce the intensity and durations of exercise. So if you have bone loss or bone metastasis, means the cancer cells spread to the bone, try avoid excessive load or high impact activity if you have bone pain, and please report to the medical team for further evaluation. If you experience numbness, tingling sensations or pain, especially in your feet or legs, or you have problems with balance or low platelets count, please ensure environment safety while you're doing exercise. If you are at high fall risk, can try to do the standing exercise with support or do exercise under supervision. And for those who has low immunity, can try to do home-based exercise and avoid crowded area to a full recovery of the immune system. And last, always check with your medical team if you have any exercise questions. So the benefit of continuing exercise after cancer treatment, like mentioned earlier on by doctors as well, it can improve overall survival, reduce the risk of cancer recurrence, reduce the risk of other cancer, improve overall health-related quality of life. It can also help to prevent or improve other medical conditions or chronic disease. So that's very important that the benefits of exercise disappear if you stop your training. So if you can, if you're okay, choose a sport or activities that you are interested in and right for you, so you can stick to your exercise routine more easily. Just a quick mentions about exercise in patients with palliative treatment. The benefit of exercise or physical activity during end of life is not yet established as compared to patient in curative cancer treatment. However, a potential role for physical activity as a supportive care intervention seems promising. So some studies actually suggest that exercise can reduce the symptoms of fatigue and improve physical functions and well-being in patients with palliative care. So remember, every physical activities count. Even if you are weak, try to start where you are, use what you have and do what you can. Here are some online resources if you want to start some simple exercises at home. So you can search the Health Promotions Board YouTube channel for some exercise for elderly, older adult in different fitness level and in different language. There's another 15 minutes workout that lead by physiotherapy and is suitable for all age on the NCIS and UHS YouTube channel. So now we come to have a look at some good example of active aging. On the left-hand side is Joanne McDonald, who only started her training at 70 years old for some health concern. So she has hypertension, arthritis, was difficult to get up and down the staircase because of pain. So now she looks very confident and fit in her 75. On the right-hand side is the representative from Singapore. They are a group of uncles and agongs aged between 60 to 80 who want to encourage senior citizens and everyone to maintain a healthy lifestyle and age actively. So do look them up on the social media page if you need some motivation or inspiration for starting exercise. So it's never too late to start exercising. Yes, I end my presentation and thank you for listening.
Thank you, Sing. Next up, please welcome Ms. Sarah Lee. She's a dietitian from the Department of Dietetics and Nutrition at Ng Teng Fong General Hospital. Sarah specializes in oncology and runs the dietetics clinic for cancer patients, including older patients in the outpatient setting. She will be sharing with you on nutrition in cancer care for older adults. Over to you, Sarah.
Thank you for the introduction, Mei, and good morning, everyone. Thanks for tuning in today. My name is Sarah, and I'll be speaking on the role of nutrition in cancer care, and I hope you find something helpful out of it today. So let's begin. Okay, to start off with, why bother with nutrition? Okay, maybe some of you are not convinced that good nutrition plays a crucial role in cancer care. So you might be asking that question, but let me try and convince you. Firstly, cancer is very complex. Okay, let me show you how complex it is. Wow, it's like so complicated, right? Like even I don't understand every single thing on this picture. Okay, but basically when there's a tumor, it triggers all sorts of negative responses in your body that causes inflammation. Now, I'll spare you from the complexity of the science behind it, but essentially, the body goes into a condition that we call cancer cachexia. Okay, what is this cancer cachexia? Now, basically, it is characterized by unintentional weight loss. Everybody wants to lose weight, right? But this kind of weight loss is bad because it is unintentional. No good reason also will lose weight. Okay, there is also fat and muscle wasting. That means you will get weaker and weaker and weaker. And on top of that, there is a loss of appetite. And on top of that, as you get older, your muscles will waste away faster and faster. And all these will lead to a very malnourished cancer patient. It's very scary, right? So what will happen to someone so skinny? Basically, things like lethargy and fatigue, weakness leading to falls, reduced quality of life, and unfortunately, delayed cancer treatment. So if cancer patients don't take good care of their nutrition while they're fighting the cancer, they will end up in a very bad shape. And that's why good nutrition is so crucial when it comes to cancer care. Okay, but perhaps your question now is, what actually makes a good diet to fight cancer? Okay, if you forget everything else today, this is the main take-home message from my presentation. Okay, CP need CP. Cancer patients need calories and protein. Okay, let me explain. Have you come across some of these statements about food that should be avoided or taken when someone has cancer? No sugar or carbs because it eats the tumor. No seafood because it is poisonous. Must have brown rice, fruits, and vegetables. No red meat because it causes cancer. Or no milk because it's too heaty. What do you think about these? Are they true or false? Now, let me give you some time to think about it, whether they are true or false. Now, actually, the answer is false. What we want to do for cancer patients is to liberalize, not restrict. Okay, what does that mean? It means cancer patients should be set free. They can eat whatever they want, and we shouldn't say they can't eat this or they can't eat that. Why? Because when someone has cancer, your body needs all the help it can get to fight the cancer and undergo treatment. They need all the fuel they can put into their body. Now you think about it, cancer patient suffers from the loss of appetite, so they don't feel like eating. And if the things they want to eat, you say cannot eat, then it will actually increase their risk of malnutrition. So that's why we say CP needs CP. Okay, cancer patients need calories and protein. Calories give them energy, and protein helps to fight against muscle loss. So prioritizing calories and protein in their diet can help to prevent further weight loss. So first, let's talk about the C, okay, calories. How do I increase calories? Well, the answer lies in fat and sugar. Now, what do I mean? Food that is high in fat and sugar would usually also be high in the C, the calories. So if you take in more fat or more sugar, you are taking in more calories. So let's take a closer look. As much as possible, try to include healthier fats in your diet first. Now, some examples include things like nuts and seeds. But I know for some older patients, it might be very hard to bite. So you can either crush them or give nut butters instead. Or you can try things like avocado, which is very soft, and you can make it into a milkshake or use it to spread on bread. And speaking of spreads, soft margarine contains good fats, which you can easily spread on bread or crackers as well. Oily fishes like salmon, tuna, sardine, mackerel also have good natural fats that are high in calories. And lastly, we want to include more healthy oils like canola, soybean, sunflower oil, corn oil, peanut oil. Add them when you're cooking. Okay, let me elaborate further on this. Food fortification is a great way to increase your calories. And what do I mean? Basically, it's like making your food stronger by adding more fats. You know, we always encourage cancer patients to 加油 to fight cancer well, right? Then when you prepare food for them, you must also 加油. You must also add oil. For example, you can add extra oil to the stir fries, or if you want to fry the chicken wing, you know, don't just shallow fry, you can deep fry. You can add extra gravy or rice or curry to the rice, add extra sesame oil to the porridge, to the egg, to the fish, or fry rice or noodles instead of just serving plain rice or plain noodles. Okay, let me show you why food fortification is so helpful. Okay, for example, here we have a bowl of rice. Okay, it's about 260 calories. Okay, but if you fry the rice, okay, and add lots of oil, eggs, and maybe some prawns, the fried rice becomes about 500 calories. Oh, you see, it's like doubling the calories that easily. Okay, another way to fortify your food is, for example, if you like to eat bread, you can spread one of these things on it. So bread plus gaya will give you more calories than just plain bread. And when you spread, don't be so kiam siap lah. You spread thick layer, you know, like those wayang makeup. All right. Now, okay, if your appetite is very, very, very bad, okay, very bad, and you don't feel like eating much, okay, it's okay to eat some of these outside food that are high in fat. Okay, for example, nasi lemak, roti prata, char kway teow, chicken rice, mee rebus, fish and chips. Basically, these are things that are high, that are more oily. Now, you don't like this, KFC, McDonald's also can lah. Now, one thing I will say here is that it sounds very unhealthy, right? Okay, normally if you have no health issues, as your dietitian, I will advise you to eat these things in moderation. But for a cancer patient who can't eat much or is losing weight, every mouthful counts. We want every mouthful to be packed full with calories that the body needs. So it is okay for those battling with cancer to eat more oily food. Now, what if you don't like all this hawker food? That's okay. You can also eat some of these snacks, and you see it's all these oily ones, right? But that's okay because they need more calories. They need more C calories. So if the cancer patient likes Old Chunky, it's okay, you can buy for them. Or if they like goreng pisang, also can. Okay, another great way that you can introduce more calories into the cancer patient's diet is by desserts. So for example, ice cream, cakes, ice kacang, dessert soups like pulut hitam, or some kuehs and pastries. Okay, but if the cancer patient has diabetes or poor sugar control, then maybe desserts wouldn't be so suitable for them. In their case, they should focus more on including more fats in their diet, like those examples I gave earlier. All right, so you remember our tagline, CP needs CP. Okay, now we know how to increase the C, but how do we increase the P, the protein? Okay, let me share with you some examples. Some sources of protein include things like chicken, pork, beef, fish, prawns, eggs, fish balls, tofu or tau hua, legumes, yogurt, and milk. So try to include as much of these food into every meal whenever possible. Now, some cancer patients might find it easier to drink rather than eat, especially when appetite to eat is lost. So when they have a drink, they can prioritize fluids that contain sugar or fats or protein. For instance, soy milk, full cream milk, milkshakes, fruit juices, sugar-sweetened drinks, or adding more condensed milk to their coffee, tea, or Milo. Now, okay, in summary, CP needs CP. Cancer patients need calories and protein. If you forget everything else from this talk, this is one thing to remember, okay? CP needs CP. Cancer patients need calories and protein. Okay, so I've told you all the different kinds of food that cancer patients can eat more of to increase their C and their P, calories and protein. But what else can we do? Okay, here are some hot tips for you. Okay, aim to eat small, frequent meals. So for example, if they can't eat 3 big main meals, then they can eat 5 to 6 small meals instead. They take advantage of times when appetite is at its best to eat as much as possible. If they feel like eating, just wait. Let them eat as much as they can. Okay, number 3, enjoy more of their favorite foods. So don't go and give them brown rice when they don't like it, or like vegetables if they hate it. If they like to eat chicken rice, just give it to them. If they like to eat roti prata, let them eat. If they like the food, they will eat more, and that's good for them. Okay, 4th is to avoid drinking large amounts of fluids before meals, as it will make you feel full. If the cancer patient drinks until they're so full, they won't have space in their stomach for C and P, the calories and the protein. So that's actually bad for them. Lastly, eat with family or friends, or listen to your favorite music as you have your meals. If the cancer patient does something they like as they eat, or eats with people that they like, that will help them be in a good mood. And when they're in a good mood, then they will eat more. Now, there's one more way that you can help them, and that is by using oral nutritional supplements. These usually come in the form of a milk-based or juice-based product. Now, when I'm seeing a cancer patient, this is actually a very important step to improve their nutrition. Why? Because they are packed full of C and P, calories and protein. Okay, let me show you. You take a standard common nutritional supplement like Ensure. Okay, 1 can of Ensure is about 250 ml, has similar calories and protein to about 3/4 bowl of rice with an egg. So you drink that 1 can of ensure, it's like eating like half of your meal already. Okay, another example is Resource 2.0, which has even more calories and protein than ensure. Now, drinking 1 bottle of Resource 2.0, about 200 ml, is almost like you just ate a plate of wonton mee or a bowl of mee soto. It's like mee soto in a bottle. So it's very easy to increase their C and their P, the calories and their protein. But the truth is, there are so many different types of supplements out there in the market. I can't even put them all into this one slide. So how would you know which one exactly is suitable? The simple answer is let your dietitian decide for you, because that's our job. But you might wonder, what exactly do dietitians do? Well, in a one-to-one session, we would gather your weight and diet history. And after conducting an assessment, we would provide a diet education, teaching you strategies to improve your diet, a tailored meal plan, and finally, prescribe supplements that are suitable for you. If you need to be tube fed, we will also tailor a regimen specially for you to optimize your nutritional status. So before I end, I would like to leave you with this quote. Don't wait till it's too late to see a dietitian. If you have more questions about nutrition or you need a thorough assessment, ask your oncologist for a dietetics referral. Remember the picture of a very malnourished body I showed earlier? Well, usually when patients like this walk into my clinic, or if I see them in the hospital when they are admitted, there's only so much I can do to help them. And sadly for some, it's too late already. Some of their fat and muscle loss is irreversible. So if you're concerned, arrange to see a dietitian at your next visit to the doctor. So that's all I have for my presentation today, and I hope you find something helpful, which you can start doing now. Thank you.
Thank you, Sarah, for the very amusing and light-hearted sharing. I really enjoyed your catchphrase for cancer patients, calories and protein. I believe this addresses also a lot of misconceptions about food and cancer that people may actually have. All right, so moving on, our next speaker is Ms. Joey Chen. She's a senior pharmacist from the Department of Pharmacy at Ng Teng Fong General Hospital. She has a passion to empower older patients and their caregivers to take charge of their medication through understanding their goals and needs. Joey will be sharing on some of the important tips on managing medication with her talk, Polypharmacy in Older Adults, Do's and Don'ts of Medication in Older Adults with Cancer. Joey, please.
Okay, hi, good morning, everyone. Thank you for spending this Saturday morning and afternoon with us today. So today, I'll be sharing some tips from a pharmacist's perspective regarding how you can manage your medications and take charge of your health. So firstly, I'll be going through what is polypharmacy and what we can do to manage the negative effects of it. So it's more the merrier or it's lesser better for you. And I'll also be sharing regarding supplements and herbal products. What are the benefits and the risks associated with their use? After that, I'll be sharing on vaccinations for the older patients with cancer and should we consider vaccinations for them. Then I will also conclude with some general tips for good medication management. So first off, what is polypharmacy? So there are quite a lot of definitions available online, but for the sake of this presentation, I'll be using the definition by WHO, which is the concurrent use of multiple medications, including over-the-counter, prescription, traditional, complement medicines that are used by the patient. Usually, in our current practice, we will consider a patient to have polypharmacy if they're consuming 5 or more medications on a regular basis. So you may have heard that medications are beneficial in maintaining health and preventing progression of the disease. But does that mean that more medications are better? So as mentioned by the doctors earlier, as the human body ages, the kidney and the liver, they may have reduced function. So the kidney and the liver, they play a very important role in the processing of medications in the body. So reduced function of these vital organs may increase the exposure of the body to the medications. And also as we age, there's an increased likelihood for long-term health conditions such as your diabetes and high cholesterol and high blood pressure. So with such conditions, patients are more likely to be taking an increased amount of medications. So keeping those two factors in mind, there'll be a increased risk of adverse events from the medications. And in patients who are frail, they may also have lesser reserves to deal with these side effects of the medications. So with more medical conditions and with more medications, the risk of medications worsening other disease conditions increases. So one example would be, let's say a patient is constipated now, and then he takes a painkiller, which has a side effect of constipation. So these combined factors will lead to a worsening of constipation. So if the use of medications are so risky, so will lesser medicines be better for me? That means lesser risk for me. Well, the use of multiple medications in combination are beneficial in some conditions, such as in heart failure, in which there are established clinical trials, clinical studies, showing that this fixed combination of medications are able to improve survival rates. And in diabetes, sometimes a single medication will not be sufficient enough to control your blood sugar levels. So the doctor might choose to add another medicine to help to bring down the blood sugar level further. So good control of blood sugar levels can help to protect other organs in your body, such as your eyes as well as your kidney. In kidney disease, as you recall, the kidneys are one of the key organs in the body that helps with the removal of toxins, maintenance of the electrolyte levels, as well as water balance in the body. So with poor kidney function, the body might need some extra help in removal of these toxins and the removal of this excess water, as well as the maintenance of the electrolytes in the body. So various types of medicines can help to maintain the balance in the body. So by not taking these essential medications, it may actually hasten the progression of the disease, increase the risk of disability from these complications of the disease, increase the rate of hospitalization and even death. So after all that is said, polypharmacy is not all bad, but neither is it without risk. In the following slides, I will explore the different measures on how we can prevent the negative effects of polypharmacy. So how can we achieve a balance between the benefits as well as the risk of polypharmacy? So one of the things is the creation of a medication list. So your medication list should include any supplements, any over-the-counter medicines that you're purchasing, or any herbal or traditional medicines as well. So an example of the medication list is shown over here. So you can write down the patient's name, the date in which the list was compiled, as well as any medication allergies that the patient may have. So after that, you can also write down each patient's medication name, what was the latest dose that was prescribed by the doctor, and why are you taking these medications. So this will help you to be aware of the different types of medicines that you're on, as well as the reasons why you are taking these medications. So the medication list, it should be reviewed after every doctor's visit. And then you can also have a discussion with your clinician, like what are the changes made? So example, if a medication has now been discontinued, you can draw a strike through the item, and then that's it. And if there's a new medication, you can also add it onto the list. So such a list will help you to keep track of the medication changes that are done, and then what is the reason behind such changes. So I think there's a very common issue that a lot of patients do come to the pharmacy is that I still have a lot of medicines left at home. So what some patients do, and I also would strongly recommend it for everyone, is before you seeing your doctor, you can actually count the number of medicines that you have at home and then write it down on the list as well. And when you come to the pharmacy, just let us know how much medicines you have at home, and we can just minus out accordingly. So in the way, we'll help to prevent wastage of your medicines at home. So moving on to the next point is that how about other medicinal products that you would like to try, but they are not prescribed by your doctor? So as per what my previous colleagues have shared, you can always ask your healthcare provider, such as your physician, your dietitian, or your pharmacist, if this product is suitable for you. And by suitability, we will take into account the potential benefits as well as the risk it provides to your condition. So you can ask your healthcare provider regarding the use of over-the-counter medications, supplements, as well as traditional medicines. So another way to prevent the negative effects is to request for resource materials from your healthcare provider to help you to understand the decisions being made during your consultations. So it may be very daunting to be started on new medications, especially medications that are used for the treatment of cancers. So as you know, when we open up the medication package, you see a whole long list of negative effects of the medication, and it can be very, very daunting. So in our pharmacy, we do have patient counseling sheets like this. So we will actually explain to you what are the expected side effects of the medication and what you can do to manage these side effects. So if you have any other questions regarding the medicines, you can also feel free to discuss with your pharmacist during the session. And not only in terms of the adverse side effect, we will also be providing you information on how you can handle the medicine, how you can store these medicines well as well. So what is a health supplement? So the Health Sciences Authority has defined it as a product that is used to supplement a diet with benefits beyond those of normal nutrients and to support or maintain healthy functions of the human body. It cannot be used as an injection, and it cannot be a preparation that is sterile, such as your injections or your eye drops. So it also cannot be part of a meal or a diet. So I will not be going through what's good about supplements, what is not so good, and what is bad about it. So what are the benefits of such products? It can help to replenish essential substances the body needs for function, such as your iron, your vitamin D, and your vitamin B12. So some of the products can help to reduce the risk of disease, such as the use of vitamin D together with calcium may help to reduce the risk of fractures in certain group of patients. And also some medications or some products may help with the management of side effects from chemotherapy. However, the not so good part of such products is that there is a lack of high quality scientific research on their benefits and their risks, with their effectiveness of such products not being regulated by HSA. So there are some clinical trials which have been conducted, but usually these trials are quite small in size and may not truly reflect the extent of the benefits and the risks such products may pose. Many of these trials may also be sponsored by the manufacturer of the product, so this may lead to some form of biasness when the research is published. So, unfortunately, due to the lack of high quality evidence, many of such products may cause side effects when combined with other medications, including your chemotherapy. So a very, very popular example will be the use of American ginseng. So it's quite popular for its use in helping to reduce blood sugar. But when you're a diabetic patient, sometimes the doctor may have chosen to start you on other anti-diabetic medicines. And when such things are used in combination, it will actually further increase the risk of hypoglycemia, which is low blood sugar. So in Singapore, the safety of such products are regulated by HSA, so in which there are regulations in place to ensure that a product is not laced with any Western medicinal ingredients, or it does not exceed any limits of heavy metals or other chemicals which are toxic to the body. So however, in this day and age, we are all increasingly well connected to the world through the internet. And so this comes with the benefit of being able to purchase close to anything from anywhere in the world. And with so many online sales available, especially like the 11/11 sales that just happened. So there might be a lot of things that we buy at a really, really good price. So when we buy supplements from overseas, they may not be regulated by HSA, and they may be contaminated with Western medications. So an example, a product that says that it will be able to help you to reduce inflammation may actually be laced with steroids. So how can I ensure that the supplements or the herbal products that I'm purchasing is safe and beneficial for me? So how do I be a smart shopper for my supplements and my herbal products? So it's always, the first thing is to use non-commercial websites. So one example will be the Food and Drug Administration website. They are based in the US. So bringing back to my previous point that I mentioned in the earlier slide. So many of these supplements, they lack robust clinical trials to test their effectiveness and their safety. So similar to the advice that is given when you're investing, if the returns, or for this case, if for supplements and herbal products, if they sound too good to be true, it probably is too good to be true. So a lot of the products also are labeled with words such as natural. So natural does not equal safe. And many of the products, they act in many different areas of the body. So it may exert in areas of like the products say that it can help with the eyes or it can help with your breathing. But in reality, the medication might also act in other areas that you do not want it to be. So it might also interact with your current medication therapy, including the chemotherapy that the doctor may choose to put you on. And this may affect the effectiveness of such a therapy, or they may even increase the toxic effect of such therapy. So I cannot stress how important it is for you to discuss with your healthcare team, which includes the dietitian, the doctors, the pharmacists, when you are considering to take a supplement or herbal product on top of your prescribed medications. So we can help you to see if this product is safe and beneficial for you, and then you can make an informed decision whether you would like to take this product or not. So another hot topic in this season will be vaccinations. So there is an increased risk of infections in the elderly, and this may be especially increased if they were to undergo chemotherapy. So some of the commonly seen infections in this group of patients are like influenza, pneumococcal, as well as COVID. So as we have been seeing on the news and on various media outlets, an unvaccinated patient is at higher risk to experience the serious side effect of disease. So vaccinations can help to reduce hospital admissions, the time you spend in the hospital, as well as to reduce complications and death from the disease. So the vaccinations that we do offer in the Geriatric Clinic are COVID, and we also do recommend the yearly influenza vaccination, as well as the pneumococcal vaccinations. So medication management is a very complex task. So for myself as a pharmacist, the names of medications are quite a mouthful to pronounce. So some patients are taking multiple medications with multiple different dosing. So this is definitely not an easy task. And I would like to say to all the patients and their caregivers in our midst today that you are doing a fantastic job in managing your health, because it's really not an easy task. So unfortunately, for some elderly patients, and even some of us, we do have trouble performing this task. So as caregivers, so we will need to pay attention to their ability to perform medication management, and we will need to provide assistance when necessary. And as a pharmacist, I'll be more than happy to be able to assist you in this process as well. So some general tips is to take your medications on time. So do not stop or alter your dose without first discussing it with your doctor and your healthcare team. So set a reminder on your alarm clock or your smartphone to help you to remember to take your medicines. And in this day and age, there are multiple applications available to help you to remind you to take your medications. So you can also make a check mark on the calendar after each dose. For those who are not so tech inclined, this is one method that you can just tick the days along as you go. And the use of a pill box will help in the management and the organization of your medications. So an example would be capecitabine, which Dr. Angela mentioned earlier. So capecitabine is a bit of a tricky medicine in that the dosing might be a bit more like you have to take for 2 weeks and then you have to rest for a week. So in our pharmacy, we do provide a calendar like this to help you to keep track on whether you have taken your medicines for today. So you can always request for such materials from the pharmacy as well. So we'll also advise you on how to store and handle your medicines properly. So you can always check with your pharmacist or check on the labels of the medication on how to store your medicines. Whether does a medicine require refrigeration, or when should you throw the medicine away after opening. So always wear gloves when handling the medication, as some of the medicines, especially for chemotherapy, may be harmful. And keep the medications away from heat as well as moist environments. Keep on, of course, to keep away from children and from pets. And to dispose your medication in a safe manner. So if you are unsure, always check in with your pharmacist if you require any help, and especially with disposal. So as I've mentioned previously in my talk, always consult your pharmacist regarding any questions that you may have regarding your medication therapy. So we can discuss with you on how these medications can impact your health, and we can also advise on the various side effects that you may experience and how you can manage them. And we will also advise on the safety as well as the interactions of the medicines that you may be thinking to take. So example, if you like to use certain supplements or certain traditional medicines, do get in touch with your pharmacist or even discuss with your clinician on how this may impact your current therapy. And we can also advise on medical devices because like inhalers, they can be a bit fiddly to use. And so we'll be more than happy to be able to show you on how to use them. as well as we'll be able to advise on how to store and handle your medicines appropriately. So pharmacists, we can do a lot more than just giving you medications over the counter. So through discussions with you, we can find out what matters to you most. And together with the healthcare team, we can help to guide your decision in your medication therapy. We will want to help to reduce the risk that you experience while increasing the benefits that you get from your therapy. So in summary, polypharmacy is a double-edged sword, but together with your healthcare team, you can play a part in reducing the risk and as well as maximizing the benefits that you get out of your medical therapy. And supplements and herbal products may be beneficial, as I mentioned earlier, but that does not mean they come without risk. So always discuss with us before you want to start. And vaccinations are very essential in preventing disease and death and complications of disease. And always check in with your healthcare provider if you are in doubt over the suitability of any medicines or any supplements or other herbal products that you would like to take. So thank you so much again for your kind attention, and I will be glad to take any questions.
Thank you, Joey. I guess we really need to applaud on the task that older adults and their caregivers are doing for managing their medication, as it's not always easy to do that. Finally, please welcome our last speaker, Ms. Tiffany So. Tiffany is a principal medical social worker from the Department of Medical Social Services at Ng Teng Fong General Hospital. Tiffany has been working as a medical social worker for more than 15 years, and she's part of the geriatric oncology team in providing financial assistance, long-term care planning discussion, and providing psycho-emotional support to geriatric patients with cancer and their family caregivers. She'll be touching on some of the challenges commonly faced by caregivers of elderly cancer patients with her talk titled, Caregiving Journey, Pleasant or Perilous. Tiffany, please.
Okay, I hope all of you can hear me well and good. Thank you for the intro, Mei Ling. We are finally coming to an end of today's webinar. Really would like to thank all of you who stayed on till this very end. Before I start, for those of you who need a good stretch, please do so. Give yourself a good stretch and I'll start in 5 seconds. Okay, and I'll start. Now, my presentation today will be focusing on caregivers and the caregiving journey. Family caregivers play a vital role in caring for an older person with cancer. They provide essential support for the person that healthcare system cannot provide. So caregivers should be regarded as a valuable resource. So often family members are thrown into this caregiving role suddenly and they may not be prepared for the challenges. Hence, the program like ours aims to provide guidance and support caregivers through their caregiving journey. So there are 4 parts to my presentation today. I'll be covering on the impact of caregiving on caregivers, stance of caregivers, which is collaborative, either collaborative or colluding, resources for the caregivers, and self-care for the caregivers. Okay, before we look at what are the impact of caregiving on caregivers, let us understand and examine what are the roles of a caregiver to the older person with cancer. Now, because an older person with cancer may differ greatly in their function, frailty, and cognitive ability, the demands of caregiving will range from providing just supervision to assistance to complete care of a highly dependent elderly. So tasks like providing physical care, showering, dressing, doing household chores like marketing, cooking, right, and planning what nutritious food to cook for your loved ones. What we heard from Sarah, CP is very important, right? Be the emotional and spiritual, support and pillar for the elderly with cancer, especially if the person is facing side effects from treatment, which is often very unbearable. Managing finances, decision-making, coordinating medical appointments, and even learning. So continuous learning is important. And for the caregivers attending this webinar today, this is exactly the reason why you are here, right? That is to learn. Right? There have been numerous studies done to understand the impact of caring for the person with cancer, with a focus on understanding the degree of burden experienced. Now, caregiver burden is defined as the extent to which caregivers feel their emotional or physical health, social life, and financial status have suffered as a result of caregiving. Now, let's take a look at how caregiving impacts the physical health of the caregivers. Now, studies have found that the most prevalent physical problems reported by caregivers are sleep disturbances, tiredness, pains, body aches, loss of strength, loss of appetite, weight loss. Now, stress may have a negative effect on the function of the immune system, blood pressure, and cholesterol of the caregivers. In a study done in the US, it was found that a high level of stress in elderly spousal caregivers may be a risk factor for death. In terms of mental health, studies have shown that depression is greater in cancer caregiver, particularly those who are caring for an older person with severe or terminal illness. And other studies have shown that anxiety is also prevalent in caregivers. Now, when we look at psychosocial factors, we're looking at disruptions to the caregiver's routines, right? Less socializing and a sense of interpersonal loss. Many studies have reported that caregiving disrupts social connectedness as the caregiver's energy and time are focused on the older person and their recovery. So this in turn resulted in less time for hobbies, social isolation, and loneliness in caregivers. Now, lastly, caregiving takes away time that might otherwise be spent in paid employment. Right, so because it's a 24/7 job, I mean, caregiving is a 24/7 job. So on top of that, you know, the caregivers may have to be burdened with the treatment fee, medical bills, right? And all these may drain the financial resources for the caregivers. Now, the long-term impact on the caregiver will then include like loss of savings for retirement. Now, while caregiving has negative consequences, it can also have its rewards. So in one Australian study, 60% of caregivers were able to identify the positive aspects of this role. So caregivers describe the time spent with their loved ones with cancer as precious time, allowing them to explore emotions and expressions of love. Caregivers also reported in another study that they felt proud and satisfied that they had spent quality time with their loved ones. They expressed that they felt feelings of value, feelings of self-worth. They were also able to accept the eventual death of patient and work through their grief. The stance of caregivers. Okay, so the stance of caregivers towards how much they prefer their loved ones with cancer to know about their diagnosis, the prognosis and treatment has an effect on the care planning process. So what do I mean by stance? So are we adopting a collaborative stance or a colluding stance? I'm going to spend a little bit of time to describe what is collusion here. Now, in the course of my work with patients and their caregivers, I've seen caregivers who, out of love and protection for the older person, requested the doctor and the team not to disclose any information regarding the patient's diagnosis, prognosis and medical details. Now, this act of withholding information is known as a collusion. Now, many studies conducted have shown collusion to be fairly prevalent amongst patients with cancer. Percentage ranges from 37 to 55%. But how about patients' preference? Do they actually want to know about their diagnosis? Well, the answer is yes, right? Various studies have shown a great majority of them do, right? Ranging from 80 to 95%. Now, evidence also suggests that sensible disclosure of diagnosis and prognosis is important and is associated with a better quality of life in the older persons with cancer. Okay. Now, the opposite of colluding would then be collaboration. So looking at this Venn diagram in a pictorial sense, this is how collaboration in care planning looks like. We consider the patient's wishes and preferences, family's ability, and hospital's recommendation collectively in this whole process of care planning. Okay, this slide further elaborates the good and bad of collusion. Now, we can understand that caregivers are trying to protect their loved ones from knowing the bad news with regards to their diagnosis and prognosis, but there are actually more disadvantages that come with it. I'd like to share a story of one of my female patients in her 70s during one of my sessions with her daughter. The daughter told me that she does not want me or the team to mention the details of her mother's cancer condition. So the mother only knows that she has a growth and she has to undergo treatment for it. Now, as a medical social worker, my role then is to work closely with the daughter to manage this collusion situation. So firstly, I acknowledged the presence of collusion and the difficulty of the situation that the daughter is facing. I reviewed with her the reasons why she does not want her mother to know. So according to the daughter, she shared with me that her mother has a weak heart, so her heart cannot take the bad news. And her mother is also usually a person who thinks a lot and are easily anxious. So if we give her the details of her condition, she may think too much and sink into a depressive state. So she felt that as her daughter and main caregiver, she feels she has the filial duty and obligation not to disclose her mother's medical condition. I then asked her, what does she think is her mother's level of understanding of her condition? I suggested to her that most patients would actually like to know the truth and that they may already be aware that something serious is happening. I also shared with the daughter that withholding the truth and presenting a false reality could prevent the patient from sorting out practical issues and denying the patient opportunities to reorganize their lives, goals, hopes, and aspirations. So especially for her mother at this age in her 70s, she may have unfulfilled wish, unresolved issues that she may want to settle. So, but I had to pace this I tread this rather carefully with the daughter because she comes across as quite strong-headed, with a strong opinion that she knows best for what is the best for her mom, right? So I had to pace this conversation along with her, giving her the time and space to think, would this be what mom really wants? Would this be her preference and her wishes? Okay. Next, I'll be covering on some resources that caregivers can turn to alleviate the stress in caring for the older persons with cancer. So this diagram essentially shows the resources ranging from home-based care, center-based care, to community-based, residential care, palliative services, and financial assistance. I'll give a quick summary of what the various resources are for. Okay, so home-based services, center-based, and residential services, collectively, they are known as intermediate and long-term care services, or ILTC in short. So as you can see, home-based services include services like home medical, home nursing, home therapy, home personal care. So say, for example, if the older person has a stoma bag and requires stoma care, then home nursing services can actually come in to provide that sort of care. If the seniors have problems getting to the hospital for the medical appointment, so that's where we can put in home personal care, which is the medical escort and transport service to bring the elderly for their medical appointments and treatment. Center-based services would include daycare, day rehab centers. So these centers provide opportunities for the elderly to participate in social activities and having social interaction with others. Physiotherapy and occupational therapy, they are available in day rehab centers. If caregiving for the elderly gets too demanding and too difficult for the caregiver, so that's where, like just now, Dr. Nidia mentioned in one of the story of the elderly person, the elderly person may, end up in a nursing home. The caregivers may think of wanting to put the elderly in a nursing home because caring gets too difficult. Okay. Community-based services. So cluster support and community case management service are examples of community-based services. A team of case managers will assist to coordinate the services needed by the older persons and provide regular contact through home visits or phone call to check in on them. Now, for caregivers who need emotional support to talk about their stresses, there are counseling services provided by organizations like Singapore Cancer Society or like SAGE Counseling. Then there are also support groups for patient and caregivers to participate, to share their personal experience and gain new perspectives from other members or cancer survivors. Financial assistance is available for subsidized patients who are seeking treatment in a public healthcare institution. So examples of financial assistance for treatment bills and medication will be Medifund Assistance and Medication Assistance Fund, but the patient must be eligible for the criteria to apply. There are AIC financial schemes as well. They are varied, Pioneer Disability Assistance Scheme, Senior Mobility Fund. So usually a person must require assistance for his activities of daily living before he can be eligible for most of the schemes. I'd like to talk a little bit about this caregivers training grant. So caregivers training grant is a $200 annual subsidy that allows caregivers to attend approved courses by AIC to better care for their loved ones. And home caregiving grant is a monthly $200 cash payout to support your loved ones who require some assistance to perform 3 or more of the ADLs. For more information, you can actually go to AIC website, which is aic.sg, and there is actually quite a detailed write-up of the various grants, the criteria available to apply for the grants. Right. As the cancer of your loved one progresses, now caregivers may need help to manage the complex illness. So this is where palliative care can come in to improve the quality of life for the older person and the caregivers and to provide support to them. Costs of ILTC services are kept affordable as there are government subsidies provided through household means testing and usage of MediSave for some of these services. So as you can see, home hospice care will be, providing services at home for the person, hospice daycare where the person will be attending the center to get some social interaction, and inpatient hospice care. This will be more suited for persons who are at the terminal till end of their condition, and what they do in the inpatient hospice is management of symptoms for the persons with cancer. Right. Next, I'd like to share about advanced planning and legal tools. So what I meant by advanced planning would be starting early conversations on care needs and arrangements with your loved ones should they lose mental capacity in the future. Now we can see there's advanced medical directive, lasting power of attorney, advanced care planning will. So I would like to focus on advanced care planning, ACP in particular. ACP is actually the process of planning for one's current and future healthcare. It includes discussing one's personal beliefs and goals for care with their loved ones and the healthcare provider. So in Ng Teng Fong Hospital, we have ACP facilitators to carry out this open conversation with patients about their values, their goals, and preferences for care. So in the event that this person loses his mental capacity, this prior discussion will then guide doctors and the nominated healthcare spokesperson to make decisions in the best interest of the patient. Okay, lastly, I would like to end off with talking about self-care for caregivers. We all know that self-care is important, right? Self-care is basically defined as the practice of activities that individuals initiate and perform on their own behalf in maintaining life, health, and well-being. So example of self-care practices, having enough rest, physical activities like exercising, eating healthily, social interaction, meeting up with family members, catching up with friends, being spiritually connected, and management of stress. Caregivers who pay more attention to their own physical and psychosocial emotional health are better able to handle the challenges of looking after their loved ones. So this is, after all, a long journey. It's a marathon, it's not a sprint. So it's very important that you stay healthy to walk this journey together with your loved ones. Okay, I think this is my last slide. Okay, thank you.
Thank you, Tiffany. I acknowledge that caregiving journey is indeed challenging, and having the knowledge and accessibility to these resources as well as self-care is fairly important to the caregiving journey. So thank you for your resourceful presentation. May we now invite all speakers, Dr. Ng, Dr. Angela, Dr. Nidia, Si-Ying, Sarah, Joey, and Tiffany to be back for the Q&A session, please. Please note that the questions selected in the Q&A chat box may not be asked in order of posting. Due to the overwhelming number of participants, we will have to prioritize questions pertinent to our topic. Okay. Okay, maybe I'll direct the first question to Dr. Ng. We have a question from the audience. My grandmother in her late 80s did a colonoscopy during later hospitalization due to other conditions. Doctor found that her intestinal walls perforated during the scope. After that, she was found to be anemic. As there's such a high risk of perforation during colonoscopy, Is it not safe, therefore, to go for annual colonoscopy?
Yeah, thank you for the question. I'll just highlight 2 points regarding this question.
Sorry, Dr. Ng, your audio, I think there's a bit of a technical issue. Dr. Ng, you're muted.
Are you able to hear me now?
Yes, very clearly.
Okay, can. All right, thanks for the question. There are 2 points within this question that I would like to address. The first is there's no need for annual colonoscopy. So if, depending on the risk profile of the patient, if the first scope is normal, in general, for average population risk, we will advise the next colonoscopy to be done 10 years later. So there's certainly no need, not many conditions that require an annual colonoscopy. The second question, the second part of this question addresses the perforation risk of colonoscopy. Colonoscopy is generally a very safe procedure for a diagnostic scope. That means we're not doing anything big, doing big resection for the colonoscopy. The perforation risk is less than 1 in 3 to 4,000. So it's very, very small. And therefore, I mean, it's unfortunate. It certainly can happen, but it's very unfortunate that this occurred in the case of your grandmother. Thank you.
Okay, thank you, Dr. Ng. Dr. Pang, does immunotherapy treatment apply to older colon patients?
Thanks, Mei. So that's quite a good question. So really, immunotherapy is currently one of the newer forms of treatment for cancers. And the indication for colon cancer really is in people with advanced, i.e. stage 4 colon cancer, who are tested to be likely to benefit from immunotherapy. So which means maybe only a small proportion of patients with colon cancer would benefit from immunotherapy. So not everyone. So really, if you have questions about immunotherapy and the suitability for your loved ones or yourself, do have a word with your doctor and check with them whether your loved one or yourself is suitable for immunotherapy.
All right. We have another question for Dr. Ng. My mom, 63 years old, has been diagnosed with metastatic colon cancer. She has no existing condition. The doctor advised her to only do chemotherapy and not surgery. Is this what will you advise by yourself too?
Okay, thank you for the question. Firstly, there are different kinds of patient profiles. Just based on whatever has been typed in this question, for metastatic colon cancer in general, our goalpost, our aim of treatment is essentially for quality of life rather than quantity of life. So our goalpost is not quantity of life, but rather to make sure that they are as comfortable as they can. In such cases, because surgery, there is the price to pay for surgery is an investment. There will be stress, there are complications, there will be pain, financial costs for surgery. If there is no crisis, okay, so if there's no obstruction, if there's no perforation, there's no incessant bleeding, in general, we do not advise for surgery in such a case. But of course, each case is different. So we will need to deep dive into all the deep details of the patient before we can make a sensible advice. Thank you.
I'll direct one question to Dr. Nidia. What is your opinion and the issue of hiding a cancer diagnosis fact from the aging parents?
Okay, thank you for the question. I think Ms. Tiffany has covered this quite a fair bit in her talk, but I'll just like to add on to that. So most of the time when we want to withhold the diagnosis of cancer from our older loved one, it's actually well-intentioned. We're trying to protect them. We don't want them to worry, but often it's because of our own fears as well. But having said that, the older person is actually more resilient than what we give them credit for. And being blissfully ignorant in that sense may not actually be a good thing. We don't know what's important to them, what they value. So having that discussion with them, engaging them in the management of their condition is actually very useful. We want to know what is important to them. It may not be cure. It may be for example, that a trip that they're looking forward to make with their daughter, or seeing their grandson being born, or waiting for their son to get married. So all these things probably are sometimes more important to them than actually prolonging their lives at all cost. So having that honest discussion actually gives them this opportunity to express their wishes and their thoughts. And it may be difficult, it may be distressing for you to actually have that conversation with your elderly loved one. So as much as we encourage you to have that discussion, if it's difficult for you, it can also be done with the healthcare professionals so that we can give a more balanced evaluation of the issue. We don't just give just the bad bits, but also the good bits. Yeah, so I would actually encourage family members to have this honest discussion with their loved ones. Thank you.
All right, thank you, Dr. Nidya. I have a few questions for Dr. Pang. Okay, the first question, I have an uncle, 82 years old. He has COPD and his CEA markers went up a bit and the CT scan reflected a growth and was advised to do a biopsy. He's very active and move around without any problems, only feeling breathless sometimes. He's undecided and discussed with me. I asked him, number one, after biopsy, if it's cancer, will he go for treatment? 2, after treatment, he may not be as active as before. Will he be able to accept? I'm not sure if I'm putting this question to an elderly when approached in a correct way.
Wow, it's quite a challenging situation, I must say. But if in reality, we do see a lot of patients like your uncle in our clinic, they are quite elderly in their 80s, but actually they're otherwise quite fit. So I would say our usual standpoint is that if, let's say, after all the evaluation and workup, and you are indeed a fit elderly who is able to receive cancer treatment that will offer you a cure from your cancer, and yet the treatment options do not cause you to compromise your quality of life, we would definitely support you and encourage you to go through with it. But I think the questions that you posed to your uncle are not invalid. They are actually quite practical and very rational. Some of these questions we do discuss with our elderly patients for them to have a thought about before going through with treatment. But I would also recommend that, since he has all the investigations worked up and done, the conversation really should be held with his doctor. And if you are his accompanying next of kin, there with him, it will be great if all these questions can be addressed in the same setting. Yeah, so and for elderly patients, that's precisely the reason why we have our geriatric oncology clinic with the whole panel of everyone here, really to support fit elderly patients like your uncle to be able to go through the treatment and survive the cancer, thrive with the cancer well, as Dr. Nidya put through in her slides earlier. So yeah.
Right. I have one question for you, Dr. Pang, pertaining to stage 4 metastatic colon cancer. There's actually 4 questions to this one single question.
Sure.
Yeah. So the first question is, what's the risk of dependence if cancer patients has a hereditary gene? Second, if the dependents have the gene, what are the chances of getting colon cancer? Third, currently in medication science, how many genes are proven to result in colon cancer and what are they? And the last question, doctor is trying to add in anti-EGFR drug, but due to hereditary gene, it was mentioned they can't. Why is that so?
Okay, I think this is a little bit scientific, so we kind of have to take it as a broad overview. So I think there are 2 parts to this question. The first part is how likely is one with colon cancer to have an inherited risk of colon cancer? So there are probably 2 more common inheritable kind of colon cancers. There are 2 syndromes called FAP, and the other one is called HNPCC. And typically in patients like this, the person who is diagnosed is usually relatively young, and there's usually a fairly strong family history of cancers in the family, not just colon cancer, perhaps colon cancer, uterus cancer, as well as other types of cancer. So really, when we look at the risk of it being inherited, we look at the entire family, including uncles, aunties, grandparents, granduncles, and such. So the risk, the proportion of colon cancers that are inherited is no more than about 10 to 15%. So majority of colon cancers are not inheritable. The other part of the question is about the molecular mutations within the tumor that is being tested. So I think the question pertaining to EGFR antibodies being added to the treatment is really the testing, the molecular testing on the tumor shows that this particular patient, cancer will be unlikely to respond to anti-EGFR treatment, hence the reason why your doctor would not recommend for it to be added in your case. Yeah, I hope this answers the 4 questions above.
All right, Dr. Angela, we have one more question from Facebook. In short,
Yeah.
is there a cure for stage 4 colon cancer?
Well, I would say stage 4 colon cancer in general is a fairly advanced cancer, which means the tumor has already spread from the colon to another organ, which is beyond the original site of the cancer. Generally, it would generally mean that what we can offer would really be treatment to control the cancer and not be able to offer a cure, but only for selected groups of patients where the tumor is only localized to the colon and one other site, like for example in the liver, and it's a very small volume spread, then with very aggressive treatment with chemotherapy, surgery, and in some patients with rectal cancer, even radiation as well, we may be able to offer a 30 to 40% cure. But as I mentioned, only for very selected patients where the cancer has not spread to multiple places. Yeah, but otherwise, for most patients with stage 4 colon cancer, we would be able to offer chemotherapy and supportive care to ensure that, the cancer is being controlled and you do not get too much complication from the cancer nor the treatment that is offered for your cancer. Yep, I think that's about it for the answer.
I have a question for Dr. Ng. How do I go for cancer screening? And should all patients still undergo major surgery for cancer?
Okay, thank you for the question. 2 parts to this question. How do I go for cancer screening? I think the most sensible, the most easily available, in fact, is free for most, as I said during my talk, will be to do a stool test, a fecal immunochemical test. Now, this is readily available, but we must just bear in mind that if it's positive, we will eventually lead to a colonoscopy. Another way is to do a colonoscopy outright from the start, but of course, it's an invasive procedure. It's a little bit more risk than the stool test, which is obviously almost no risk at all. And in such cases, you can actually go through a polyclinic to get a referral to the public hospital or see a private surgeon for a colonoscopy. Now, the second part of the question relates to, so what's the second part of the question again?
Okay, can older patients still tolerate,
yes.
So sorry, should all patients still undergo major surgery for cancer?
Okay, so the oldest patient that I personally have operated on is 93 years old, and she has done well. Okay, so as we have been mentioning again and again, no 2 elderly patients are the same. We have to look at their physiology, that means how they are. Well, some 94-year-old people can still rule a country, still govern a country. So really, age itself is not prohibitive. Okay, so I think do consult with your surgeon, do consult with your oncologist to determine the best way ahead for each and every elderly patient. Yeah.
Right, thank you, Dr. Ng. I have one question for Ms. Sarah. Cancer patients or cancer survivors are often very thin looking. How do you put on weight healthily?
Yeah, yes, you are right. They usually look very, very thin, fortunately. There are a few ways, okay. Number one, I'll recommend the oral nutritional supplements because that's the easiest and the fastest way to increase their calories, to increase their weight or prevent weight loss. Now, these supplements, although they are like milk or juice, they are actually quite special. They are specially formulated, not your normal milk or juice that you get. So they are packed with calories and protein. Try to include them into your daily food like Milo or coffee, tea, or your drinks. Put it into your oats mixed together or cream soup. That's one way to include the supplements. Okay, that's for oral nutritional supplements. The second way is what I mentioned in my talk was to include more good oils or fats into the diet. Okay, like the nuts and seeds or like avocados or the oily fishes or the healthy oils. the healthier choice symbol kind of voice. So sometimes patients will tell me, but then like I have diabetes, like I don't want to be so liberal with my diet. The question is actually, we need to prioritize what the problem is. If your diabetes is well controlled, but you have cancer, then we want to prioritize the cancer. You know, that is about choosing which battle to fight first. All right. Yeah, I think that's all I have.
Okay, Ken. Si-Ying, I have one question for you. What can I do if my family member is not motivated to do exercises?
Okay, yeah, actually many people, not just the cancer patients, find it hard to stay motivated when it comes to exercise. Yeah, especially cancer patient maybe experience some discomfort or distress or having other priority over exercise. So as a family member, so it's very important we can support them through the journey. And it's very important, remember, every physical activity counts. So instead of suddenly ask them to do a 30 minutes of exercise, we can help them to become more physically active first. So for example, invite them to go for a walk after meals, or ask them to do some simple housework. And also help them to set a short or long-term goal. For example, or if you are fit, then we can go for some family outing together. If you're getting much better, then we can go for overseas trips together, something like that. So at the same time, acknowledge their small progressions, and yeah, sometimes maybe reward them with some nice food or something like this, and buddy up with them to encourage them to stick to the exercise. So just slowly build up the routine for the exercise. Hope this answer.
Okay, thank you, Si-Ying. I have a question for our pharmacist. Is multivitamin pill supplement recommended for seniors tackling cancer?
Hi, Mei-Ling. Thank you for the question. So in terms of multivitamins, multivitamins, as the name suggests, it does contain a whole host of vitamins inside. And usually when a patient undergoes treatment with us, the doctors, the clinicians, they will check the patient for any deficiencies in their bodies, and then we can replenish it accordingly. So in terms of multivitamins, some of them, they may contain ingredients which may interact with the current therapy. So again, it's very important to check in with your doctor or the pharmacist whether this is suitable for you.
Okay, thank you, Jerry. I'll pick the last question to Ms. Tiffany. How do I apply for Medifund or financial grants?
Okay, so first of all, you have to be a subsidized patient in a public healthcare institution. So have your doctor refer you to a medical social worker. So the medical social worker will do a financial assessment on whether you are eligible to apply. As for financial grants, again, if you're seeking treatment in a public healthcare institution, there are AIC satellite offices in all the public healthcare institutions. So you can approach the AIC satellite office for more information, or otherwise you can go to their website, aic.sg, to get more information on how to apply for those financial grants.
Okay, thank you for all our speakers. We have come to the end of the afternoon session, and we would like to thank everyone for your keen participation and support. We do hope that this session has been insightful for everyone. Lastly, we gladly appreciate if you could complete the feedback form at the end of this webinar. Thank you and stay safe.